the pattern of the examination, the trend of the examination. We have amazing team of faculties with us live with you all today. We'll have different faculties explaining about the questions asked in the respective subject. This will give you the insights and the trends, and I'm sure this active discussion, right, will give you a complete analysis of the paper that is conducted yesterday. And to begin with, I think we have our medicine faculty, one of the loved faculties of medicine, Dr. Rahul Rajiv sir, with us, who will be, interacting with you all. Major subject and a very heavyweight subject, especially for your paper two. And before that, about a few words about the exam, if I can tell you. Uh, if you see the paper, yesterday's paper, right? If we have seen yesterday's paper, the paper one, as most students had said, the paper one was a very easy to moderate paper, mainly preclinical subject with sufficient time with the new pattern. So many students gave a very, very positive review for the new pattern. The two good things that happened with the new pattern is students could focus in those 50 questions before changing the set. Many students said that, sir, it was like we were resetting and we were getting alerted before the next set starts. So that was a good insight. And what students were getting afraid that these multiple sets would be a setback was actually a blessing in disguise for the students. And the time was sufficient for many students. And to talk to you about the different subjects, let the subject faculties discuss with you. And a lot of questions in paper two were slightly more clinical and more oriented with lot of images actually, including most of trouble was with surgery. So I'll would invite Dr. Rahul Rajiv sir to start off with the medicine discussion. We'll have different faculties. We have Gayatri ma'am, Rohit sir, right? I think Rahul Rajiv sir, we can start with you.
Yeah, thank you so much, sir. I hope I am audible and visible. Yes, sir. Am I audible? Hello? Hello?
Yes, sir, you're audible, sir.
Okay. So, sir, can you see my screen?
Yes, sir, your screen is visible, sir.
Okay. So, good evening to all dear students. We'll have a very quick recall of the questions asked in the recent FMG exam pertaining to most of the subjects in this session. So at the outset, let me tell you that the discussion that we are going to have now is not going to be an exhaustive one. And I'm sure that at this point of time, the students who have just written the exam, they are not much interested in a detailed discussion. You would like to know the answers only. So we'll go for just a very crisp discussion, just the question and what is the answer. A detailed version of this discussion will be uploaded in the app. So once we get the full correct version of the question, we'll be recording this and we'll be having separate recall sessions of each subject to be uploaded in the app. So let me just quickly go through the medicine questions. Well, medicine, as you know, is often linked to other subjects as well. So the questions that I'll be discussing in this recall session will be pure medicine as well as some questions integrated to other subjects as well. So there is a possibility that you might see some repetition with my other colleagues as well. But again, we'll just have a quick discussion now. Okay, so moving on to the various questions. As I said, just the question and the answer. Question number one was a migraine patient with hypertension, which drug to be avoided? So you know that triptans, they will cause vasoconstriction and hence you have to avoid triptans. So sumatriptan should be avoided in such patients. Second, there was a scenario of a patient with absent seizures. And as you know, the drug of choice for absent seizures is ethosuximide. And the question asked was regarding the mechanism of action of ethosuximide. Again, question integrating both medicine and pharmacology. It will inhibit the T-type of voltage-gated calcium channels. Now, third question, again, I think some of the students wrote this by logic itself. The question was a clinical scenario of an acute bacterial meningitis. And what was asked? The long-term complication was asked. So in the options, you had all these infarcts, which were all short-term complication. Remember, the long-term complication that can develop is hydrocephalus. CSF analysis, as always, we had two questions this time rather than one. So one was a clinical scenario of a neutrophil predominant, leukocytosis in the CSF. So that was acute bacterial meningitis. That was one scenario. Then a lymphocyte predominant pleocytosis with hypoglycorrhea, which means reduced CSF glucose. And that scenario is that of a tubercular meningitis. Okay, right. Two questions from myasthenia gravis this time. So one was a clinical scenario-based question where they gave a patient with a fatigable ptosis worsening towards evening. Simple question, the diagnosis was asked. And what is the diagnosis? Myasthenia gravis. Another question for myasthenia gravis is they were asking about the investigations. And what did they ask? So the students told me the question was specifically on the most sensitive test. Remember, I've always stressed in my lectures, most sensitive test for myasthenia gravis is single fiber EMG, and most specific test is acetylcholine receptor antibodies. Question number 6, clinical scenario of a patient with delirium tremens. They asked about the treatment, and it is benzodiazepine. Another clinical scenario of a patient with Wernicke's encephalopathy. Patient had confusion, ophthalmoplegia, nystagmus. They asked, what is the treatment? Simple question again, thiamine. Another question on neurology. They gave prosopagnosia term, and they asked, prosopagnosia is inability to recognize what? Remember, again, told in lectures, inability to recognize faces. Okay, they'll not be able to recognize faces. Okay. Now, coming to ECG, I was expecting, one ECG of myocardial infarction. And, I almost thought that there will be an arrhythmia-based question. But what I understand is there was just one question based on ECG. And that was an ECG with ST elevation in the anterior leads. A simple, straightforward one. It is anterior wall ST elevation myocardial infarction. Now, next question, at least a few students had doubt. First biomarker to rise in after a myocardial infarction. I'm sure your eyes were looking for either myoglobin or, as I've told in my lectures, one of the earliest biomarkers now is the heart fatty acid binding protein. But the students told none of these two options were there. The option had troponin, CKMB, and some students told me albumin was there in the option. Okay, and I think LDH was there in the option. Now, if these four were the option, the answer is going to be troponin, no doubt about it. But some students told me, sir, it was not albumin, it was ischemia modified albumin. Okay, if it was ischemia modified albumin, okay, ischemia modified albumin, this one is a novel biomarker. Okay, but if the question just had albumin, that's not the answer. But ischemia modified albumin can actually start rising within 30 minutes. Okay, so if the option was ischemia modified albumin, you will have to pick that as the answer. But if just albumin was mentioned, the first biomarker among the option is troponin. Remember, myoglobin was not in the options. That is why you'll have to pick this. Okay. Right. Then there was a clinical scenario of hypertensive emergency. They asked regarding the treatment. Some students were confused between nitroglycerin and labetalol. Remember, in common scenarios, it is labetalol that is used unless the patient is having a coexisting cardiac problem wherein you may think of nitroglycerin. So some students wrote nitroglycerin, but no, the best answer is IV labetalol. Question number 12. Simple question, mechanism of action of rivaroxaban. It inhibits factor 10A. Another simple question they asked about was regarding arrangement of the auscultatory areas in order. Again, a simple picture was given. You just had to pick up where is the mitral area, tricuspid area, aortic area, and pulmonary area. I think, again, it was a simple question. Okay, patient with vaginal candidiasis. Now, look, a few questions here from diabetes. So at the outset, let me tell you, if you see the flow of questions, usually, I think in FMG exams, you do get slightly more number of questions from cardiology compared to neurology. But for some reason, this time, more number of questions from neurology compared to cardiology. Diabetes, I think a few questions came. One I got was patient with vaginal candidiasis, which anti-diabetic agent should be avoided? It is the SGLT2 inhibitors, canagliflozin. Next question, test for monitoring long-term glucose control. I'm sure that, you would have had a smile on your face on seeing this question. These are the questions they should keep asking so that, all of us can, happily answer the exam. HbA1c. Clinical scenario of a patient with drug-induced hypoglycemia. What are the drugs that can cause hypoglycemia? Among the anti-diabetic agent, insulin, sulfonylureas, and the miglitinides. So what was given in the option? There was a sulfonylurea mentioned, that was glimepiride. Patient with hyperlipidemia, patient was started on statins. Triglyceride is persistently elevated despite statin, and what drug should be added? Gemfibrozil. Question number 18, clinical scenario of a patient with fever, chills, and rigor. Peripheral smear was given. So what I understand from the students is that the peripheral smear showed multiple ring forms. What is going to be the diagnosis? Yes, it is Plasmodium falciparum. Another question from malaria, again important. See, malaria, TB, HIV, you will have to give due importance. Plasmodium falciparum malaria treatment asked, again a simple dolly question, artemisinin-based combination therapy. Then pneumocystis carinii, I suppose there was a clinical scenario-based question. I think there was an image as well, but they asked about the treatment, and it is cotrimoxazole, which is the treatment. A drug which can have a dual action both in HIV and TB. What is it? It is tenofovir. Kaposi sarcoma occur at what CD4 count? To be very honest, Kaposi sarcoma can occur at any CD4 count. Actually, even if the CD4 count is normal also, it can happen. But again, taking into consideration the question, the best answer is less than 500. So the moment CD4 count actually drops below 500, so I think some students gave me a recall that there was a range 350 to 500. So if that is the range, you please pick up that answer. Okay. Then the next question, vector for Orientia Sutsugamushi, it's mite. Diagnostic test for monkeypox. What is the answer? It is PCR. A chest X-ray was given of miliary tuberculosis. I think there was a clinical scenario attached to it as well. Truck drivers, National Board of Examination and truck drivers is always a very good combination. And for some reason, you attribute all the retro infections, syphilis, but this time they got chancroid. So truck driver with a painful genital ulcers after unprotected intercourse is chancroid. So most common cause of anemia in a 65-year-old male. I suppose this was a googly question. If it is 65, 55, 45, 35, 25, whatever it is going to be iron deficiency anemia. I was a bit disappointed that some students wrote, it is anemia of chronic disease, but always remember in our country, what is going to be the most common cause of anemia, iron deficiency anemia. Next clinical scenario, patient with low hemoglobin, but WBCs and platelet was normal. Bone marrow showed decreased erythroid precursor. Specifically, answer is pure aplasia. Then clinical scenario of a patient with colicky abdominal pain, arthralgia, purpura. What is the answer? It is IgA vasculitis, also known as Hinox-Schondlin purpura. There was a question on ABG interpretation. From what I understand from the students, no clinical scenario given, just a strip with the ABG reports given. pH was less, PCO2 was decreased, and bicarbonate also decreased. Always remember, what is the answer? Metabolic acidosis. Change in pH in relation to PCO2 and bicarbonate, if it's in the same direction, it is going to be a metabolic acid-based problem. Okay. Then there was a pedigree chart. I suppose in that pedigree chart, it was a maternally inherited one. So I think the kids, got the disease only from the maternal side. So it is going to be mitochondrial inheritance. Again, a very simple question. Cotton dust exposure predisposes to what? Answer is bicyanosis. Simple one. Again, another simple question. Unconjugated hyperbilirubinemia is seen in, answer, Gilbert syndrome. Anti-tubercular drug causing visual disturbance. How easy is that question? Ethambutol. Another question, I think, a bit of pharmacology also into this. Anti-cancer drug causing hand-foot syndrome. It is capecitabine, which is decreased in acute inflammation. Remember, you have got positive acute phase reactants and negative acute phase reactants. What are the negative acute phase reactants? Transferrin and albumin. So they asked about the negative acute phase reactant. It is albumin. Cherry red spots, again, a very simple question. Tay-Sachs disease. Lish nodules are seen in neurofibromatosis type 1. I suppose somebody told me it was just mentioned that it is neurofibromatosis. Even then, that is the answer. Then I suppose there was a patient with a history of self-mutilation. I think he was biting all his fingers. And I'm sure this history of self-mutilation, everybody knows it is HDPRT deficiency. Another question where the karyotype was given, it was trisomy 18. And what is it? It is Edwards syndrome. Edwards syndrome. There was an image-based question showing Kessel's necklace. So another nutritional deficiency. They asked about the treatment. It is nicotinamide. Which blood group can be given to a Bombay blood group patient? Again, it is O negative blood group. Dermatitis herpetiformis is associated with which condition? In my GI lectures also, I have stressed on this point. Celiac disease, dermatitis herpetiformis is again a good combo, which is often asked in the national board examinations. Okay, the tumor marker for carcinoid syndrome is 5-HIA. And what is Zellweger syndrome was asked, again a direct factual question. It is a peroxisome biogenesis disorder. So this is just a quick run through the medicine questions which were asked. Just to sum up, if you look, most of the questions were asked from previous year topics. See, if you ask me, sir, are you quite sure that every exam previous year questions, the questions come only from that? See, what I can tell you is, in a vast subject like medicine, you have always got to take into account the probability that these questions are asked. Now, if the question, in any question paper, there will be at least a certain proportion of questions based on previous year topics. So whatever exam you appear, I think your best bet is to go through the previous year topics of the previous at least 3 years, at least. And so that, you will get a fair idea of the questions. And if you have got any other doubts, or if you have got any other additions to the questions that I've asked, you can WhatsApp me. My WhatsApp number is 9447 334944. And you can also reach out to me in Instagram, dr_Rahul_Rajiv. So that's it. Thank you so much. I hope all of you have done the exam reasonably well. It's time to relax right now. Maybe after this recall session, you can have, your party. Maybe it has already started for many, but keep enjoying the moment. Please talk with your family. Keep doing whatever you were restricting yourself from doing all these few months. And thank you so much. And looking forward to hearing your success story along with the rest of our DocTutorials faculties. And we are very eager to know your success. So please do share your success once the results are announced. Thank you so much. Over to Khalil, sir.
Thank you so much, sir, and for the clear insights. For such a vast subject of medicine, the kind of clarity, the kind of patience, and the kind of insights you bring in, I'm sure most of our DocTutorial students would have definitely benefited from such vast experience and clarity of subject that you bring into medicine, sir. And after such, insightful session for the vast subject like medicine, let's quickly move on to a shorter subject. We have Dr. Rohit Daniel, sir, with us, and ortho has been a lot of image-based and a lot of, questions are coming up recently in even this exam. We had a lot of image-based questions to go through those topics. I would invite Dr. Rohit Daniel, sir, to take up the session, sir.
Thank you, Khalil, sir. So good evening, all my students. So this is Dr. Rohit, your orthopedics faculty. So like always, this time also orthopedics, I would say, was relatively easy when you look at the whole paper. So we had around 9 questions from orthopedics. There were several questions where there were overlap with other subjects. But if you look at all these 9 questions, I would say that all of them were either directly asked from previous year questions or based on the previous year topics. I can't say that there were any new questions, all of them straightforward previous year topic questions. So I'll just share my screen now. So if you can see my screen, so I'll quickly discuss the questions one by one. So first of all, we had an X-ray of a tumor which was arising from the talus. So the various options you can see on the screen. So here you can see that there is a swelling arising from the talus with a pedicle and a expanded end. So this is your classical osteochondroma. Usually you get an X-ray of osteochondroma arising from a long bone. This time you had a lesion arising from the talus. I think most of you have got this answer correct. So this is your straightforward osteochondroma. So this question again on a fracture, but pediatric fracture, a 6-year-old child presenting with a wrist injury and X-ray shows a fracture like this. Can see that the distal radius has a fracture line. This fracture line is involving the physis. It's starting from the physis and it is going towards the metaphysis. So this is the classical Salter-Harris type 2 fracture. So that is the answer to this question, Salter-Harris type 2. If you look at the third question, you have a patient who has sustained injury to the wrist, following which there is loss of flexion of the metacarpophalangeal joints and loss of extension of the interphalangeal joints. Which nerve is injured? Again, a very, very easy, straightforward question. We all know which muscle causes the flexion of the MCP and extension of interphalangeal joints. That is your lumbricals, and lumbricals are supplied by your ulnar nerve. And whenever you have an ulnar nerve palsy, you get the loss of this function resulting in your classical claw hand deformity. So this is your straightforward ulnar nerve injury. Very, very easy question. Next question, again, a very straightforward one-liner. We have already learned this so many times. A 60-year-old man presenting with bowing of legs, his X-ray shows cotton wool skull. What is the diagnosis? Again, very, very straightforward question. This is your Paget's disease, very commonly, not very commonly, but seen in elderly males. They present with generalized bone pain and bow legs, bilateral genu varum. And when you take an X-ray of the skull, you can get the cotton wool skull appearance. If you look at the next question, again, a very, very often asked question. In fact, it is a repeat of a previous year question. Identify the bone tumor from the X-ray. So you'll see that there is a metaphyseal lesion in the distal part of the femur. And you can see that there is elevation of the periosteum with a triangular new bone formation. So this is your classical Codman's triangle. Again, we have learned this so many times. This indicates osteosarcoma. Codman's triangle showing osteosarcoma. If you look at the next question, you have a man. Very interesting question. A man was climbing stairs when an iron rod, which was protruding out, pierced his neck. His vitals were stable, but he had difficulty in shrugging the shoulders. So the question is, which nerve is injured? We know that shrugging of shoulders is brought about by which muscle? It is your trapezius, and trapezius is supplied by your which nerve? Spinal accessory nerve. So in this question, the answer is spinal accessory nerve. That is the answer here. If you look at the next question, what is the type of joint between the epiphysis and metaphysis? Again, a very, very easy question. We know that in a child, you have three divisions for the bone. You have the epiphysis, the metaphysis, and the diaphysis. The epiphysis and the metaphysis is separated by the physis or the growth plate. Growth plate is made up of cartilage, and cartilage in your joint is your synchondrosis. We know that chondros means cartilage. So whenever you have a joint based on cartilage, you call it a synchondrosis. That is the answer here. Next question. What function of hip joint is tested using the following test? You can see an image of a person standing on one leg. So this is the single leg stand test or the classical Trendelenburg test, where you are testing for the power of the abductor muscles of the hip. So here the answer is abduction power of the hip. So many students, I don't know why, have written the answer as extension. No, here we are testing for the abduction power of the hip. So the ninth question, this is the last orthopedic question. A 26-year-old male presents with TB hip. The deformity of the hip is shown. What stage of TB is it from the clinical image? So if you see in the image, you can see that the hip is flexed, adducted, and internally rotated. So there are two stages in which this can occur. So it can occur in early arthritis as well as in late arthritis. And the difference depends upon the amount of shortening. So here there is a little bit of confusion. Most of the students have told me that there was just a little bit of shortening. Then the answer would be the stage of early arthritis. But few students have informed me that no, sir, there was a lot of shortening. If that is the case, then it is the stage of late arthritis. But I think generally the question usually revolves around stage of early arthritis. So probably that is the answer. And I think most of you have written stage of early arthritis for this question. So I think that is the best possible answer here. So these were our 9 orthopedics questions. I think all of them were very straightforward questions. And first of all, I would like to appreciate all of you for putting all the effort during the last few months, studying hard and giving this exam. And I wish you all the best for the upcoming results. Thank you.
Thank you so much, sir. I mean, I think you have covered ortho and the related anatomy and image-based questions also. And Rohit Daniel sir is very active on the Insta also and helping students throughout their preparation. And after this, we have with us Dr. Shivani Jain ma'am, our ophthalmology faculty. She has been very proactive in training FMG students both in the online platform of DocTutorials and the offline in different parts of the country. And warm welcome, ma'am, and please take through the insights of ophthalmology for this FMG exam. I think you need to unmute, ma'am.
Good evening, sir, and good evening, everyone. Hello, dear students. Can you see me? My screen is shared. Am I audible, visible?
Yes, ma'am. You're audible and visible. Your screen is also visible.
All right. So I'm sure the students are very happy, relaxed, because most of the students have told me that exam was quite good. So, but definitely it was moderately tough. It wasn't an easy paper this time, but I'm really happy that ophthalmology was forgiving. I got a review that ophthalmology questions, most of the questions were doable, and they were mostly one-liners. We have 3-4 image-based questions also this time, and we have ophthalmology in a big number. So I've got almost 19 questions in ophthalmology. So let us have a quick review, a brief synopsis of what the things were there in the exam. So here, the first one, we had a picture of rosette cataract, and they asked that there's a patient who had blunt trauma and what was the cataract. So very simple question it was, the rosette cataract, very repeatedly, very commonly asked. Now, the other one was they have given symptoms which is suggestive of loss of vision due to angle closure glaucoma, because probably they have given the vertically oval pupil also. So loss of vision with vertically oval pupil is suggesting of angle closure glaucoma. Again, a very simple question. Now, the third question is again a repeat topic basically, because last year also they had given a very similar thing, that a patient who's having difference in numbers in two eyes. So what could that be? So it is something which is called as an isometropic amblyopia. A very similar question was there last year. Now, galactosemia, everybody knows that this is a cataract which is seen, oil droplet cataract that we see in galactosemia patients. All right, so this is also very, very simple and previously heard questions. Next one, blindness criteria, WHO, again, a simple one. So we know that vision which is less than 3/60 in the better eye, best corrected vision. So again, it's a very simple question. Okay, anyone who can suggest me something different here if I'm talking about some different questions? So please let me know. Then again, we had a question on the vitamin A deficiency, which was suggesting of Bitot spot. So again, very simple. Now, some students have told me that there was a question on chemical injury, but they couldn't recall. Only one student has told me that there was something related to chemical injury. What was the first step in management? So if that was the question, probably irrigation should be done, but I couldn't get all the options. But if that was it, then irrigation should be done in a case of chemical injury. Okay. Now, next, this was the only question which we do not expect from a foreign medical graduate. So, bronze beetle appearance in retina. The answer we know it is Stargardt's disease. This is considered an important topic for PG students, but we do not teach this in our regular classes. So, this was the only question which I would say it will be a new question for you all. So, bronze beetle appearance of retina is seen in Stargardt's disease. Next, this was a picture question on lid speculum. We all know lid speculum we use in several surgeries, extraocular surgeries. Now, this again, myopia. So myopia, there was a ray diagram where the light rays are focusing in front of retina. So again, very similar question was there. They asked you about hypermetropia 2 years back. This time they gave you a picture question on myopia, right? Now, again, one student has told me that there was a question related to what complication can be seen if you have a penetrating ocular injury. So if this was the question, he couldn't recall anything else about it. If this was the question, probably sympathetic ophthalmia, probably it could be one of the options and it could be the answer, but I couldn't recall this question. Nobody, I can't frame the proper question. What was that? Now, something which was covered by Rahul Rajiv sir also, multiple Lish nodules. So this was NF1. We all know that. Now, this one is Another very, very important topic we teach, we know flictenular conjunctivitis. So there was a question where you had a nodule on the limbus and they had mentioned about a poor socioeconomic status. So that was a problem-based question in OPNA, and the answer should be flictenular conjunctivitis because the patient probably had tuberculosis, and related to that, if we have a nodule, then it should be flectin. Now, some students were confused between episcleritis and flectin, but if we have this kind of history, there's a low socioeconomic status, so probably they are telling you about tuberculosis. So that is a better option, better answer. Now, the next one, this was, something which is very, very easy to be answered, but the only tricky thing was that they asked you about loss of vision where the fundal glow is lost. So loss of fundal glow, it's very, very easy for practitioners, very, very easy for us to diagnose that if you have a loss of vision, sudden loss of vision, painless loss of vision, and the fundal glow, the red glow is lost, then the case probably is vitreous hemorrhage. So another easy question. Now, very, very simple. We were expecting this question on RD. They have asked you that there's a loss of vision and a feeling of curtain. So I always tell in my class, if you have a question on a curtain-like feeling, then this is RRD. This is rhegmatogenous retinal detachment. And this simply asks you, what is the pathology? So it should be RD. Now, sir also has covered ethambutol, that there was a question of loss of vision with and which drug, the culprit drug. So ethambutol would be the best answer here. Now they ask you something about anesthesia used in cataract surgery, and probably we have different options, but the best one was lignocaine. Okay, so if they ask you about the blocks, peribulbar, retrobulbar blocks, so lignocaine should be the best answer. Now, cherry red spot again covered by sir. So we have 3 questions which are there in medicine, in pharmacology also. So cherry red spot, again, we had a question and the best answer should be here, the Tay-Sachs disease. Now, one question in the end I got about lag of thalamus. So lag of thalamus, they ask you if the patient is suffering from lag of thalamus, which nerve is injured, which nerve is paralyzed. So again, it's a simple question. The answer should be the 7th nerve, isn't it? The facial nerve, which gives innervation to orbicularis oculi. So if that is gone, you definitely will develop lag of thalamus. So this was it, guys. There was, I'm sure that something must be missed and I'm not able to get all the questions in a proper frame. So we'll get back to this very quickly, guys. Ophthalmology was easy, I think, this time. All the students were very happy. They're not even recalling the questions because they think that everything is done. Most of the things are covered also in the lectures. So guys, from my side, take care and just enjoy, just relax. You've done a lot. You've done your part. Just now, let's pray to God and be with your family and friends. Take care, guys. Good night. Thank you, sir. Thank you, Khalil sir. Back to you.
Thank you so much, ma'am. And 19 questions almost in ophthalmology, the kind of importance, and this was there in both paper 1 and paper 2. And really thank you for the insights, ma'am, in ophthalmology.
Thank you very much, sir.
And now I think we have all the favorites of FMG students, Rajiv Dhawan sir. Students were waiting to hear from you. And the ENT has been, I've got very positive feedbacks about ENT that most of the questions were from the lectures that you had covered. And over to you, sir.
Thank you, sir. Am I visible, audible, sir?
Yes, sir.
Yeah, okay. At the outset, I must say, sir, this was a moderate paper. Paper 1 was moderate, but paper 2 was, I would say, a difficult paper. And we cannot say that it was a very easy paper. I was just analyzing the surgery questions and the other question also. So the need of conceptual understanding has been reinforced one more time by NB. And I think everybody should get a clear-cut message that rote learning would not be working in the future. And there we are heading. The paper 2 is turning super clinical, and there are a lot of images, a lot of scenarios they're giving and all. And ENT was also like on the same flavor. So guys, I would not take much of a time today because we'll be having a very detailed recall on the app later on. So this is a distribution in front of you, the ear, nose, larynx and pharynx. So once again, they have given the same kind of benefit to pharynx, which they always give. So pharynx, the smallest topic in ENT, but always gives more question. And first question was let me talk about the ear first of all. In the ear, what I could recall as of now, guys, this is the set of those questions where I'm pretty sure that these topics have been asked. A lot of questions are there where I could not get the consensus as of now. So inner ear is always there, you know it. This time they went on to ask about what is giving the brain the message for balance. So some people are saying the semicircular canal wasn't the choice, and some people say crista. So crista is the end organ of semicircular canal. So whatever in the choice, you can say that, okay, that is giving the signal to the brain for the balance part out of the structure given in the choices like tympanic membrane, stapes, footplate, etc. Second very favorite topic of year is otosclerosis once again. And this was again a clinical scenario-based question. A female with bilateral hearing loss and 54 decibel hearing loss was given over there. And they had asked, what is the possible pathophysiology behind it? So it was ossicular fixation with normal tympanic membrane. So as we always discuss in the class also, in otosclerosis, there's a stapes fixation, but tympanic membrane is normal in most of the cases actually. Third, which we were anticipating to be asked in FMG exam, neonatal hearing screening. As I told in the class also that there is a national program of deafness control. And so this time they touched that audiology part for the first time. And I think you must be remembering that I told in the class also, if it's a neonatal hearing screening, it's otoacoustic emission, but high-risk screening, you need BERA. So they did not mention any high risk for the hearing loss. So it is otoacoustic emission for neonatal hearing screening. Now, pharynx, the champion topic again, adenoid hypertrophy with glue ear. So they gave a scenario over there, a child who is mouth breathing, snoring, and also he is elevating the volume of the television while watching cartoons. Look at the style. I like the style of questions, like it's not rote learning. So like we discussed in the class also, that student has to be made sit closer to the teacher in the class. So they said the child is elevating the volume while watching cartoons. It means there's a hearing loss. So very beautiful question crafted. Adenoid hypertrophy with glue ear, and they asked a treatment. So treatment was adenodectomy with the myringotomy grommet insertion. Second, again, the image-based question was a repeat question one more time, nasopharyngeal carcinoma. And they asked with a beautiful picture given of the eustachian tube area of the nasopharynx. And they asked A, B, C, D, which is the site of origin. And we always know that an area above the eustachian tube is fossa rosenmuller. And that was the correct answer, which is the commonest site of nasopharyngeal carcinoma origin. The third was the angiofibroma. So all three topics of nasopharynx have been asked. Adenoid asked, NPC asked, angiofibroma. And the angiofibroma gave two questions. One was repeat question, a young male with the often epistaxis, which we all know a triad is angiofibroma for sure. But one question which they asked from INICT level, let me honestly accept, this nobody can imagine that it can be asked to FMG student is, staging of angiofibroma. So guys, staging of angiofibroma has only been asked till now only once in INICT paper because AIMS uses Redkowski's staging of angiofibroma for operating the cases. But they asked, they gave TNM classification, AGCC or something else, and FISH. FISH is another parallel system of staging angiofibroma. This was an absolutely INICT level question. And as I always tell you, one or two questions always new question in any subject, every subject like that. Larynx, once again, they did not leave the golden topic of laryngomalacia. So they said laryngomalacia, baby, what type of stridor were you expecting? Inspiratory stridor. One question was there, which was an overlap of pediatrics with the biochemistry and ENT, very laryngismus stridulus actually is a condition seen in rickets. It's a rickets. Vitamin D deficiency lead to hypoglycemia, and hypocalcemia can lead to spasm actually. So laryngospasm happening in ricket is a known entity, but yes, it was indirect questioning that way. So vitamin D deficiency was the answer for this case. Now nose, they asked again the anatomical, clinical correlation. One question was the anterior ethmoidal neuralgia or sleudoneuralgia, which is due to the contact between the middle turbinate and the septum. So they asked about the neuralgic pain, why the patient is having pain, what is touching what. So middle turbinate touching the septum is the cause of anterior ethmoidal neuralgia. In our notes written other names also, sleudoneuralgia. And we know ethmoid bone is actually one major bone in the nose, and middle turbinate is a part of the ethmoid bone. So the name of nerve is also anterior ethmoidal neuralgia. And I think we have discussed multiple times in the videos also. The ethmoid bone fracture was another visual question. So two visual questions came in ENT as of now. One was NPC for the Rosenmuller, and other was the radiological image of ethmoid bone. They asked if the cribriform plate is damaged in the fracture of the anterior skull base. What is the possible symptom? And we all know olfactory neuron pass through cribriform plate, and the symptom will be anosmia in that particular case. So guys, this is the beauty of the paper now. and any future exam preparing person is hearing this video, they should get this message very loud and clear. The paper 1 this time was more one-liner, we understand that, but paper 2 was really super clinical, and I must not really mince my word when I say that it was very much similar to NEET PG tilt over there actually. Okay, and once again they asked the CSF rhinorrhea. So CSF rhinorrhea, old topic actually. They asked about that what is the not true about this particular entity. One was given that beta-2 transferrin is positive, which we know it's positive, and they said that we should give bed rest antibiotic. Yes, that the answer was FES. The endoscopic sinus surgery is not the primary treatment of CSF rhinorrhea, because we discussed amply in the videos also that the CSF rhinorrhea, the primary treatment is bed rest and antibiotic for 7 to 10 days. And if that does not really help the patient, then we can go for the surgical repair endoscopically. So these are the topics which have been asked. There are more questions around that, but today's session is for all the subjects to be done together to give you overview of the whole exam. And I must say that the exam overall, paper 1 and paper 2 makes a lot of people stand very close to passing the paper. And let's be hopeful. Let's really have this feeling that collectively in paper 1 and paper 2 we will cross the finishing line. And till that time, please do not really just start anticipating a result and just get panic and get anxiety. It's good time to spend for yourself. You have not done anything for yourself till for last many months. Please join a gym, or maybe go for swimming, or whatever you have not been doing for the last so many months. Now it's a time, and go out with your friends and family and have some time. Let's pray may everyone pass the exam, and I think you've done a lot over there. Okay, so thank you very much, Khalil sir, and we are hoping for a wonderful result of our students, sir.
Yes, thank you so much, and thank you for the very organized presentation. And I'm sure, and students have been giving the feedback that they have done extremely well in ENT also. Now, going forward, we have the game-changing subject. Okay, the subject that everybody were talking about after the exam, the most heavyweight subject for this FMGE July 2024, probably the result deciding subject, I would say. And we have with us our very loved and beloved faculty of surgery, renowned surgeon, and one of the finest surgery faculty with us, Dr. Rajamendran sir. And I'm sure, if you see the kind of quality of our clinical subjects, okay, one of the best in the team, I would say, with Rahul Rajiv sir handling medicine, Rajamendran sir surgery, we have Gayatri madam for OPG, some finest teachers for the paraclinical, preclinical subjects, and especially ENT, ophthalmology also. So really happy and feel very proud to be inviting such stalwarts to this discussion. Sir, over to you about surgery insights, sir. A very heavyweight subject for the students this year.
Thank you, Khalil sir. Thank you for the introduction. So happy to say that surgery paper is a moderate paper, not a tough paper like last session. Actually, the last session surgery paper was very tough, but this session is a moderate paper. As Raju Dhawan sir told, it is a classical NEET PG pattern, not a FMG paper at all. Pure clinical. Actually, without understanding the clinical concept of each topic, we cannot answer this paper. Such a nice paper. We had around 30 to 35 questions I could recollect as of now, but some students told there are around 50 questions from surgery. I have to collect slowly. So let us discuss one by one the various questions asked. I have made the category as we discussed in our class. So from general surgery and trauma, the tension pneumothorax question was there with a huge clinical impact. And where will you put the needle? Needle is put in the 5th intercostal space, mid-axillary line. And hypovolemic shock-related features are asked in the exam. So related to hypovolemia, when will be the pulse rate rises? So like that, the questions were asked. So that question is a very classical question. All questions cannot be discussed as one line, because all the questions in surgery are like a paragraph, nearly 4 or 5 line questions. So we'll be discussing a detailed session. So any doubts you have, you can post. I'm also watching your YouTube queries from the students. Subdural hemorrhage concavo-convex image was asked, and they were asking about the craniotomy, and percentage of burns was asked related to 2 upper limbs and abdomen. Some area was asked, around 18% for upper limb and abdominal, 18%, 36% was asked in burns. And head and neck, thyroid, breast, salivary gland. We had an image-based question from oral leukoplakia, usually asked in the exam for FMG exam. This time, they asked oral erythroplakia. So erythroplakia is one which is having high chances of malignancy, and fluctuating breast swelling, breast abscess is also asked. So it's again always asked conventional question. And acquired thyroglossal fistula is asked. Every question, if you see, every question is related to old question only, but they are not the straightforward same question. So usually you get a question, thyroglossal cyst, which moves with the protrusion of tongue. But they didn't ask that. They were telling a question is asked in such a way, a patient presents to you with a swelling with the moving with the protrusion of tongue, that got infected and there is a discharge coming from the fistula. So that what is it? Like that, they were telling question more or less from the same concept, but you have to think little in depth, understand the concept, then only you can answer. So it's an acquired thyroglossal fistula. Most common cancer in females is breast cancer, cancer lip and cheek image. Some image was asked there related to cancer. And as usual, you know very well, GIT, HPP and hernias had more than 50% of the questions. Around 14 questions were from GIT, HPP and hernia. Single bubble image-based question. So what electrolyte correction should be done before surgery is hypokalemia. So triple bubble appearance seen in jejunal atresia. Esophageal perforation related question on Borav syndrome is a very common question, always asked question, Borav syndrome. On doing an endoscopy, injury happened at 25 centimeter. What structure is there and at that level? It is arch of aorta and left bronchus seen at 25 centimeter. Air under diaphragm question, as usual, every year they will never miss this air under diaphragm image. So that question was also asked this time. And how will you manage with the modified Graham's patch for duodenal perforation? Where will you not do gastric lavage? So gastric lavage or Rice tube wash should not be given for patients who are having corrosive ingestion, kerosene ingestion. So these two cases, corrosive ingestion and kerosene ingestion, you should not do gastric lavage. And name the incision for appendix. It is a gridiron incision, is done in the McBurney's point. During cholecystectomy, identify the image arrow was asked. It seems the image was pointing towards bile duct. I could not get the exact image, but it is pointing towards the bile duct or portal vein. You should see from the image. And pilonidal sinus or cori fistula, one image-based question was there. And what segment is there in the liver segment was asked. So segment number 8. These are all new questions. Segment of liver, which is asked, is segment 8. But all these questions are very common national board questions. But though it is new for FMG, flask-shaped ulcer in the sigmoid colon, how is it? It is treated by amoebic colitis, treated by metronidazole. Management of ileal perforation is by trimming the ulcer and closure. Primary closure can be done for ileal perforation. Mesh placement in hernia, one new question came. This is a completely new question for FMG, but though it is being a very commonly asked INISET question, whether it is a mesh kept on lay or sublay, it is based on the image. We will discuss it in detail. Nerve injured in inguinal hernia are 3 nerves: iliohypogastric, ilioinguinal, and genital branch of genitofemoral. Now 3 nerves are injured in inguinal hernia. So urology, we had around 4 questions related to horseshoe kidney. We had a flower vase appearance, urology IVP image. Testicular cancer, the best prognosis is seen with yolk sac tumor followed by seminoma. Some students told that it's an hydrocele. CT image was asked. And renal mass, image-based question was asked from a renal mass, maybe a renal cell cancer, but we could not get the full question. So we'll discuss it in detail. Split skin graft image-based question, very commonly asked. Thiersch image, Thiersch graft image is asked in the exam. And a flap is asked in the pilonidal sinus, which is already a neat PG question. A rhomboid Limburg flap is commonly used. I don't know what flap they kept in the image. So we'll collect it and we will discuss with it. And foot ulcer, for a tropic ulcer image is asked. Tortuous vein after a trauma. So tortuous pulsatile vein is usually a AV fistula. And lower limb amputation image was asked. Probably it's an ortho or surgery. I could not collect it, but there is a lower limb amputation image was asked. System EB scan, very commonly asked. System EB scan image for parathyroid adenoma is also asked in the exam. So there are so many still more questions asked. We are collecting the questions. We will do a detailed discussion, but I will say surgery paper is not so easy, not so tough. It is a moderate paper where you can get easily 25 to 30 questions correct out of 40 questions. Easily you can crack this paper. I'm sure this year pass percentage is going to be very high. Seeing the question paper pattern compared to last year, we'll have a good pass percentage. Don't worry, relax and enjoy. So thank you, sir. Thank you, Khalil, sir, for giving an opportunity.
Thank you so much, sir, and very structured discussion. And all the students, right, this discussion is to get feedbacks from you also. The entire faculty team is available on the different social media platforms, and you can write into DocTutorials also with your feedbacks and insights, and we'll all be coming up with a full-fledged discussion in the app that will be helpful for the future aspirants also. And after that, we have another very, very important subject, high yield subject, obstetrics and gynecology, which has always been a very, very heavily tested and high yield subject in FMGE examinations. And to handle OBG and gynecology, we have with us our very own Dr. Gayatri ma'am, and she has been a very tremendous support system for these students. Once she has taken up OBG gynecology for DocTutorials, I think a lot of students have benefited from her teaching. And Gayatri ma'am, over to you, and brief discussion on the questions in OBG and Gynec, ma'am. You need to unmute, ma'am. Ma'am, you need to unmute.
Thank you so much, sir. So comparatively in this session, we had slightly lesser number of questions as compared to the previous year questions. Here, this time we had total of 27 questions from obstetrics and gynecology. And I'm very glad to say that all the questions are from the class directly itself. So most of the questions were doable. Some of the problems that students face were some of the options were slightly confusing. But OBG, I would say it is comparatively easy to moderate. It is not a very difficult question paper as such. So let's discuss the questions one by one. So again, this will be a brief discussion. I'll be just pointing the main one-liner and the answer. So one question was about the postpartum IUCD insertion. As you know, initially the postpartum IUCD can be inserted maximum up till 48 hours. So again, in the class, we have discussed about interval IUCD insertion, post-placental and postpartum IUCD insertion. So postpartum is 48 hours. Next question was a very much predicted question, which always comes, that's from hypertension. So they have basically asked regarding the various types of hypertension. So again, we have discussed how we can divide them as chronic hypertension, gestational hypertension, preeclampsia, and chronic hypertension with superimposed preeclampsia. So in this question, the period of gestation was 17 weeks. So anything less than 20 weeks comes under chronic hypertension. So this was an easily predicted question. The next question was, when should early cord clamping be done? So the correct answer is in a baby who is non-vigorous and the baby requires resuscitation. So the confusing options that students found in this was, the other option was RH negative pregnancy. So RH negative is a relative indication for early cord clamping. If you have to choose between these two answers, the best answer, as I always say, once a baby is non-vigorous, baby requires resuscitation, immediate cord clamping has to be done. In RH, again, there are two scenarios. Suppose the patient is RH negative and already immunized. That means the patient is RH negative and ICT positive. In that situation, you need not do an early cord clamping because already the harm has been done. Already immunization has happened. So in that scenario, you will not do early cord clamping. When will you do early cord clamping? It is an RH negative, ICT negative pregnancy where the immunization has not happened. So this was another option where students had a slight confusion. So as you know, the absolute indication is a non-vigorous baby, a baby who requires resuscitation. Next, there was a question on ventouse is contraindicated. Again, so we had compared between this ventouse, which is also known as vacuum delivery, as well as forceps. So ventouse is contraindicated in preterm labor. So the second option with students had confusion was, there was an option where the dilatation was 8 centimeters. So as we always discuss, one major advantage of vacuum or ventouse over the forceps is that it can be applied even when the cervix is not fully dilated. You can even apply at 8 centimeter dilatation. Anything beyond 6 centimeter, you can actually apply this ventouse. So again, the advantages include it can be applied even in a non-fully dilated, non-rotated head as well. Whereas the main advantage for this forceps is that it can be used even in preterm. So ventouse is contraindicated in preterm delivery. So that is a direct question. So during delivery of a 30-year-old patient with previous cesarean section, you find that the shoulder gets stuck, What is the diagnosis? It's a case of shoulder dystocia. When you see that the head to shoulder delivery time is more than 60 seconds, it is suggestive of shoulder dystocia. Exclusive breastfeeding is recommended. Again, this is a topic which is overlapping with pediatrics as well. So it's a direct question, exclusive breastfeeding till 6 months. What is the marker for ectopic pregnancy? So it was a pretty straightforward question. Options were estrogen, progesterone, beta HCG. The marker in ectopic, among these hormones, the marker is beta HCG. You find that in beta HCG, if it is an intrauterine pregnancy, you see a doubling over a period of 48 hours, whereas doubling is not seen in case of ectopic pregnancy. So beta HCG can be used as a marker in ectopic pregnancy. Again, you have a level known as discriminatory zone, which is again based upon this beta HCG. If the levels are beyond the discriminatory zone, that is when you expect to see a gestational sac. The next question is a very much predicted question. As I always say, it's very important. You cannot go for the exam without going through emergency contraception. Always there is one or more than one question on emergency contraception. So this was a question: patient wants to take postcoital pill. So the correct answer is levonorgestrel. The dose that you give is 1.5 milligram single dose, which is given within 72 hours of unprotected sexual. The second option, which can be slightly confusing in this was, there was an option which had estrogen along with progesterone. So again, there are regimens in which we use high dose estrogen and progesterone, which is known as used but among this, the most commonly used drug that is used is LNG, which is 1.5 milligram single dose within 72 hours of tandem therapy is used in, the answer is cervical cancer. So you use the tandem and avoids in cervical cancer. Again, CA cervix, every year there has been question. So again, we had discussed the management includes the radiotherapy and surgery. In radiotherapy, you have the brachytherapy as well as the external beam radiotherapy. In brachytherapy, you give the tandem radiotherapy. The next question, woman presents with spotting following insertion of IUD, what is the best management? So this was a slightly tricky question because of the fact that the ideal answer should have been, usually the most commonly the patients presents with pain, spotting after insertion of IUCD. If the option reassurance and observation was given, that would be the single best answer. But I heard from the students that this option was not given and there were options which included observe and antibiotics. There was one option where there was observe as well as analgesics. And there was a third option where there was observe as well as iron tablets. So many students, as this question had spotting, they felt that iron would be a good fit for here, observe and iron. But even if the symptom is either the patient has spotting or even if the patient has pain, the main management is analgesics as such. So this was a confusion many students have. So I provided the reference here from Spiroff textbook as well. So if the patient has bleeding and cramping, which are the most common symptoms after IUCD insertion, the management is with NSAIDs, which is analgesics, which not only decreases the cramping, it also decreases bleeding. So mostly students have pointed out that there was no cramping, why still give analgesics? Even the spotting reduces with the use of analgesics. So here the correct answer is analgesics, observe and analgesics. Yes. The next question was identify the contraceptive. The image that was given is shown here. This is an image of Lippis loop. The other options which were given include Mirena, multi-load, all those were given. So this is basically a Lippis loop. Next is Anemia Mukt Bharat program. What is the correct dosage of iron that is given? So we give iron starting right from the beginning of the second trimester. We give for 180 days antepartum, that is 6 months antepartum and 6 months postpartum. Again, after the Anemia Mukt Bharat program has come up, every year there is a question from this as well. So there was a very much expected question. The next question is, there is a 25-year-old nulliparous woman who has presented with uterine prolapse. There is no cystocele, rectocele. What is the treatment of choice? Again, we had divided the management of prolapse for a patient who is multiparous for an old woman and for a young nulliparous female as well. For a young female, nulliparous female, the treatment that you're going to give is sling surgery. So here the option was abdominal sling surgery. Other options such as Leaford colpoclesis, which is used for elderly women, Shirotska surgery, all those were given, which is not preferred in a nulliparous young patient. Most common cancer in Indian women is breast cancer. Among the genital cancer, if you take, it is CA cervix. So they are just asking you most common cancer overall in Indian women. The answer here is basically CA breast. Yes. Which is the menstrual cycle length is abnormal. So again, this is from the update after FIGO. Previously, if you go with the older guidelines, it was 21 till 35 days. But as I always stress, now the current one is 24 to 38 days is taken as normal menstrual cycle length. So more than 38 days is taken as abnormal. Vomiting in pregnancy is managed with, we ask the patient to take very small and frequent meals. So again, the other options like taking less fluids, all those were included. It's basically by taking small frequent meals. What is puerperal pyrexia defined as? It is basically temperature more than 100.4 degree Fahrenheit, and usually the initial 24 hours just after delivery is excluded. This is basically the fever that happens after 24 hours and usually on two separate occasions 24 hours apart. So there are basically two 24s. The first temperature happens after 24 hours, and again there are high temperature recordings 24 hours apart. So coming to the next question, patient presents with irregular bleeding for 1.5 months, 1.5 months. What is the next best management to do? So any patient, let her present with amenorrhea, irregular bleeding, in all those cases, you have to rule out pregnancy. Urine pregnancy test has to be done for this patient. What is the drug that you give to prevent neural tube defect? The answer is folic acid. Again, the dose is 4 milligram of folic acid is given if a patient has previous history of neural tube defect. Just for prevention, the dose that we give is 500 microgram as per the Anemia Mukh Bharat program. The cord clamping in third stage of labor, again, active management of third stage of labor is a very important topic. Again, from that, the cord clamping is done ideally between 1 to 3 minutes, which is known as delayed cord clamping. So there has been two questions on this. One was on early cord clamping and other was on delayed cord clamping. So both were from our active management of third stage of labor. What is the location of Bartholin cyst at the vaginal orifice? Bartholin cyst is basically located at the posterior 1/3 of vaginal orifice. Again, patient has Bartholin abscess. The management is you are going to give incision and drainage. If the patient has Bartholin cyst, the management is marsupialization. Coming to the next question, again, this is a second question which has come from the instrumental vaginal delivery, which is on outlet forceps. Outlet forceps is applied at what station? So ideally, the forceps that we use, we have the high forceps, the mid cavity, the low cavity, and the outlet forceps. Among this, the high forceps and mid cavity forceps, they are obsolete in modern obstetrics. We don't use them. The forceps that we use include low cavity and the outlet forceps. Low cavity is used when the station is +2 or above. And this outlet forceps is used when the head is at the level of perineum. So the correct answer should be head at the level of perineum. But I got to know from the students that this option, that is head at the level of perineum, was not given. The option was station more than +3 was given. So among this, the best answer is station more than +3. That is usually more than +3 means +4 and +5. So if I just write, you have +2, +3, +4, +5. So beyond, above this, we don't use the forceps, that is high and mid cavity. They are obsolete in modern obstetrics. You are going to use +2, +3. You are going to use the low cavity, and head is at the visible at the level of perineum. That is more than +3, +4, and +5. You are going to use the outlet forceps. So the ideal answer is this, but I heard that this option was not there. So the answer is going to be more than +3. Banana sign and lemon sign, direct one-liner. It is seen in neural tube defects. MTP for contraceptive failure can be done till. So as per the latest MTP amendment, you can do MTP till 24 weeks. But read the question again. They have specifically asked you for failure of contraception. If the indication is failure of contraception, you can do MTP only till 20 weeks. 20 to 24 is for special category. For contraceptive failure, it's only till 20 weeks. The ideal number of antenatal visits, again, a very important topic, very frequently asked question. Previously, they had asked about minimum number of antenatal visits. This time, they have modified it into ideal number of INC visits. Ideal visits are 12 to 15. The minimum number of antenatal visits as per the latest WHO is 8. Previously, WHO has recommended 4 visits. The latest WHO is 8, and Government of India, it is still 4. Here they have asked ideal, so the answer is 12 to 15. So you are going to call the patient every trimester till she is 28 weeks, then 2 weekly. After 36 weeks, the patient has to come every weekly, totaling to nearly 12 to 15 visits. How will you monitor the toxicity of magnesium sulfate? Again, this is a second question on hypertension. Hypertension has been always a very high yield topic. So the toxicity of magnesium sulfate is going to be initially measured by checking the deep tendon reflex. You see that the deep tendon reflex are absent because this magnesium sulfate has a very narrow therapeutic range of 4 to 7 milliequivalent per liter. We are going to monitor for deep tendon reflex, the urine output of the patient, and the respiratory rate. Coming to the final question, in a patient who is undergoing trial of labor after cesarean section, what is the correct statement? So there has been various statements. You have to have an emergency cesarean section facility available at all times before you take the patient for a trial. Because if at all you see that there is any evidence of scar descent, you suspect that the patient might undergo a uterine rupture, you have to have all facilities to do an emergency cesarean section. So these are the 27 questions which I could get from OBG. If at all you have any more questions, any disparity in the options, or any doubts you have, you can ask me at any time. You can contact me on Insta as well. My ID is OBG_with_Gayatri. Okay, so you can contact me at any time. So all the very best for the results as well. So this is a time, don't be too stressed, relax, enjoy for some time. Our blessings, prayers are with you, and I'm sure all of you are going to do really, really well.
Thank you so much, ma'am. And we have a lot of positive feedback for your sessions, and the kind of encouragement and support you consistently give is phenomenal, and has made OBG Gynec easy for most of the students that preparing for the FMG through DocTutorials, ma'am. Thank you so much.
Thank you.
And after that, we have anesthesia faculty Ashish Karthik sir, who's a very renowned anesthesia, very practicing anesthetist, and are one of our core clinical faculty, especially handling a lot of clinical training parts also at DocTutorials. Ashish sir, your insights into anesthesia for FMG. Oh, sir, you need to unmute, sir.
Hello, good evening, Dr. Khalil sir, and my dear fellow colleagues, teachers. It's happy to see we have around 9 questions on anesthesia. I'm trying to get my screen on. Yeah, I hope it is visible and audible.
Yes, sir.
Okay. We have around nine questions from anesthesia, and almost all of them are just repeat, except for one question, which is just is an extension of what we have learned. In fact, this is the first question. Local anesthetic which has no topical action used for injection-free cataract surgery. So they have specifically asked this question because they wanted to know whether which local anesthetic is used for an injection-free cataract surgery. And the answer here is the B, proparacaine. Paracaine is the one which is usually applied topically and left it for some time, and they do the phaco surgery. If it is an injection surgery, like if you want to give a peribulbar block, then probably lignocaine would have been the option. So we need to exactly find out how the question came. But these are the two possibilities. If it is an injection, the most common one is lignocaine, and if it is topical, it is procaine, proparacaine. Okay, procaine is basically used for an oral surgery. So this is the differentiate. This is the only question which is extended from the local, the routine teaching. Now, first all is all very famous repeat question. Most common agent used in total intravenous anesthesia. Everyone knows that it is propofol. So it is so popular, so common, repeatedly asked question. Which is the drug which is used in total intravenous anesthesia, propofol. Okay. Now the third question in the CPR. This is for the last 4-5 years there has not been a single paper without a question on CPR. This has been repeatedly asked question. So here they have asked the same question. What is the ratio of compression to ventilation? It is 30:2. I know all of you remember that whether it is one rescuer or n number of rescuer, it is always 30:2. Now, which drug brings about its primary action via acting on NMDA receptor? You know, almost all anesthetic drugs act through GABA, most of them. The only few exception which you have to learn is the drug of choice which act on NMDA receptor. The drug which act on NMDA receptor is ketamine. It acts at a subcortical level. I'm sure all of you would have gone through this, learned this, and would have by hearted. So you would not have any issue regarding this. Okay. Now, another question, very practical question. This is about it's an ABG. It's from the emergency medicine department. You get a clinical question, very simple question. Usually they don't ask this simple, but however, they have been kind enough to ask this question. They just gave you values of pH of 7.1, TCO2 at 28, PO2 at 94, and bicarb of 18. So whenever you see 7.1, you know it is typically you are dealing with an acidosis, and whenever you see a significant fall of bicarbonate, it is always a metabolic acidosis. You can see that there is a gradual washing out of carbon dioxide, which is just a compensatory mechanism which has started. Okay, so it's a very simple question again. And another very, very famous question which has been repeated multiple times. What does ASA1 means? American Society of Anesthesiology classification. Usually they ask 2 and 3 to confuse you, but here again they were very kind to ask you that ASA1. So nobody make a mistake. It is healthy individual. So it's a very, very simple question again. Now, Mallampati scoring, same, no questions, no question paper without Mallampati for the past 4-5 years. So this is again another, usually they ask pictorial question, but again here what I could recollect was it was not a pictorial question. They just simply ask you, what does Mallampati scoring refer to? It is assessment of oral cavity for an intubation difficulty. As you know, all of you would have studied the various grading of that. Anyway, they have not gone to that level, and it's very easy question. Now, most common drug which is used for reversal of neuromuscular blockade. This is basically a neat question which has been extrapolated to FMG. But again, in FMG, we have gone through this. Usually, they ask a combination. What is the most common combination used? But here, again, it has made simple by just asking which is the most common drug used for reversal. The answer is neostigmine. As all of you know, usually the combination is neostigmine with glycopyrrolate. Since they have specifically asked for the reversal agent, we will rather go with neostigmine among the options. So I hope these were all very simple questions, except for the first one, which had a mild degree of confusion about the recall. Once we get more details of that, we will come back to you. And I hope all of you will be enjoying this time. And you are so lucky to have all these teachers together trying to help you. Thank you, Khalil sir, and dear teachers to be with us. And thank you, DocTutorials, for the opportunity which we had. Thank you.
Thank you so much, sir. And I'm sure students must have had a very high score rate in anesthesia. And thank you for the insightful session, sir. And after that, we had forensic tested heavily also in this FMG exam. And to take you through forensic, we have our beloved JP sir, our very, very very, very dynamic, I would say, our youngest of our team. JP sir, up to you. Can you share the screen, sir?
Yeah, 1 minute.
Sir, I think Ashish sir, can you stop the screen sharing?
Okay, I hope. Thank you very much, Dr. Khalil, and good evening, everybody. Hello.
Yes, sir. You are audible, sir.
Yeah, you can see my slides.
No, sir. I mean, you need to share your screen, sir.
I shared already. Not showing?
Yes, sir. Now it's.
I think Ashish.
Can you try now, sir? Again.
Hello.
Yes, sir. Now it's sharing, sir. Now the screen is shared, sir. You can discuss.
Okay. It has come now?
Yes, sir. You're audible and the screen is visible, sir. Please go ahead.
Okay. Good evening, my dear students and everybody, and FMGE July 24, and I'm having about 14 questions here. A dead body has been brought to the, yes, mortuary with burns over right upper limb, right lower limb, and front and back of abdomen. One of the easiest question, and you know all of you Wallace rule or rule of 9. And here you can say very well, right upper limb 9%, right lower limb 18%, so 27% plus front and back of abdomen 18%, 27 plus 18, total it is 45%. One of the easiest question. In question, case of death in police custody done by, you know very well, judicial magistrate inquest is compulsory in case of when death takes place in police custody and where a person disappears from a police custody or rape takes place in police custody. Inquest has to be done by judicial magistrate, not by executive magistrate or police. As per Pregnancy Amendment Act, in case of pregnancy due to contraceptive failure, termination can be done maximum up to the gestation period only up to 20 weeks in case of failure of contraceptive in a woman or her partner. Okay. The color of post in case of death due to burns. In case of burns, what happens? There will be liberation of carbon monoxide. The inhalation of carbon monoxide give rise to the formation of carboxyhemoglobin that give rise to cherry red discoloration. So here the answer is cherry red discoloration. Number 5, it is again one of the most repeated question. Chronic alcoholic has come to the hospital. The signs and symptoms of hallucination, hypertension, agitation, confusion, disorientation after stoppage of alcohol since 2 days. The diagnosis is delirium tremens. There is nothing to discuss. Identify the image after death. If the eyes are opened, then there will be deposition of foreign bodies and cellular debris as triangular patch on both the sides of cornea, known as tachynoidila-sclerotic. Okay. Intracranial hemorrhage which cannot be washed off. Look here, I'm showing you 4 pictures. Extradural hemorrhage, you can just wash it off. Subdural hemorrhage, you can just wash it off. Intracranial cerebral hemorrhage, you can just wash it off. But subarachnoid hemorrhage, it is seen within transparent arachnoid matter. Even if you pour water, it will not be washed off. Okay, so answer is SAH. This question, whether it is there or not, I'm not 100% sure, but some people said that it is there. I know very well. Cadaveric spas. Another very easy question. What is the most common source of bleeding in case of extradural hemorrhage? Another easiest question, rupture of middle meningeal artery. Okay. The test banned by Supreme Court of India to opine that whether the girl is habituated for sexual intercourse is, previously they used to do something called two-finger test, but Supreme Court has banned that test. That it is a general knowledge. Okay. It has come in newspapers several times. Excessive fear of heights is known as acrophobia. Maybe psychiatry. We may say forensic psychiatry. Overlapping is always there. If a dead body is found in advanced stage of decomposition, what is the best method to identify the dead body? In case of advanced stage of decomposition, anyway, bone is available. You can take the femur, or you can take the molar teeth, or you can take the hair root sheath, and best is DNA fingerprinting. DNA fingerprinting. Okay. The fracture which is seen in a pedestrian after initial impact with the car is known as. Normally, the most projected part in a car or in other general vehicles are bumper, Bumper comes and hits, usually it hits just below the knee and give rise to a wedge-shaped fracture, and it is known as bumper fracture. See, there is a difference. Strictly speaking, orthopedics, what they say is bumper fracture means fracture of lateral tibial plateau. But in case of forensic medicine, whatever the bone fractures by hitting impact by the bumper, we call it as bumper fracture. Neuroletharism is caused by which toxin? During drought and all, people may consume a dal called kesari dal, which contain beta-oxalyl aminoalanine or BOAA or BOA, which give rise to paraparesis or quadriparesis, that is known as neuroletharism. So these are the 14 questions from forensic medicine. All 14 are what I feel easy. Of course, for me, everything looks easy only. But a student level, what I feel, at least out of 14, some 10 to 12 are easy only. Okay. Okay. Thank you very much, Dr. Khalil, and each and everybody, including DocTutorials, all the faculty, all the students. Thank you very much. Good night.
Thank you so much, sir. I think you have helped us all a lot of discussion on SDH, the subdural hemorrhage question that was being in the FMG segment discussion from the last couple of days. And thank you so much. And we have the next subject of dermatology. We have with us Pallavi ma'am. She is also, done very active teaching for dermatology, both in online and offline, and actually involved with the FMG training also. Ma'am, your insights into the dermatology part. Ma'am, we can't hear you. I think there is an audio issue at your ends.
Am I audible now?
Yeah, ma'am, you're audible now. Please go ahead, ma'am.
Screen is visible?
Yes, ma'am.
Very happy to say this time, sir, that almost all the questions from dermatology were the ones that were expected. Most of them were asked in the previous year's papers. Direct repeat questions have been given. One or two questions slightly confusing will always be there. But overall, I'm saying I'm very happy with the paper here because, this is a paper that should give 100% marks in dermatology, moderate paper. And I hope these 9 questions here will take you across the mark which all of you want. So very happy with the paper here. All of the favorite topics that I keep telling through and through the discussions, these topics always expected, always asked. And I also tell through the classes that, for all the students hearing to this paper who have to give the exam the next time, always go through the NEET PG and the INI CT papers of the last 3 years as well. You don't have to bother reading the explanations, but just look at the questions, because there is often, a repeat or an overlap that comes from there. And this is what happened in this paper also. So the first question asked almost every exam over the last 10 exams, as well as asked in the NEET PG last 3 years. Patient with this clinical image, which I think all of you can tell me, what is this? This is Casel's necklace. What will be the treatment given for it? Niacin. So vitamin B3 deficiency, niacinamide. I am sure all of you got it right. Again, this is a repeat from June 2022 paper. Identify the variant of psoriasis in the image below. So they have told you that the diagnosis is psoriasis. You just have to tell the variant. You see these small patches all over the body in a child. What do you think it is? Yes, this is guttate psoriasis. Another question that often comes with it, associated with streptococcal pharyngitis. So this is like a very classic and a very expected image-based question here. Guttate psoriasis. STDs can never not be a part of the paper. So yes, here is a very typical question from STDs. A high-risk patient, a truck driver, presented with multiple painful ulcers over penis and scrotum. What is the diagnosis? The question is very clear. It tells you high-risk patient with multiple painful ulcers. So as I always tell you, whenever you see a genital ulcer, first make out whether it is painless or painful. So painful answer can be either chancroid or herpes. So the confusion here was that both chancroid and herpes were there in the options. So when you say multiple painful ulcers over different parts in the genitalia, you have to think of chancroid. Herpes will always be grouped lesions present at one spot, and they will be vesicles. So here it says two different areas, penis and scrotum. That should take you towards chancroid. So the answer here was this. Then this is a slightly tricky question, often asked in INI-CT, but histopath of bullous disorders, that too DH. One-liner, as the presence of Poitier's abscess is expected, but to give an actual image was slightly, making it difficult for the students. However, the question says patient presented with itchy papillovesicular lesions over the body. So when it says papillovesicular lesions, you have to start thinking of bullous disorders. When it says itchy, think of subepidermal. See the biopsy, the cleft is below the epidermis, subepidermal. So one thing is for sure, you have come to a subepidermal disorder. Then just beneath the cleft, you see a lot of neutrophilic collections. What is this? This is telling you these are Poitier's abscess. Now, which of the following is associated with the Poitier's abscess? Which disease is it? This is dermatitis herpetiformis, and the association we have read through and through all the classes is celiac disease, because the antigen is common here, that is transglutaminase. So this was a slightly difficult question, I would say, because you had to identify the biopsy. But these are some classic biopsies. So for the next paper, please make sure to go through these ones. The Nikolsky sign is positive in, that's a very simple one-liner. It is positive in intraepidermal immunobullous disorders. That is the pemphigus group. Very easy to rule out the other options also. You just had to look for pemphigus, and that is the answer. Now, this question was there in the January 2023 paper, a question on inheritance of this disease. Here they have given you an image. So just a year later, they have given this question as a repeat. What do you see? You see multiple cafeoli macules and skin-colored swellings in the image, which are neurofibromas. So what is the diagnosis? Neurofibromatosis. That is a very simple one here. So I hope this image, all of you got it. Again, I will say this is a repeat. So all the questions that we have discussed till now have been repeat questions. Then this is a repeat from 2019, as well as one more time after that. It's an overlap with pediatrics, pathology, and dermatology. So what does the patient have? This child has abdominal pain, arthralgia, hematuria, and multiple raised red lesions over the leg. So when you have this, what is your diagnosis? This is Hinoch-Schonlin purpura. In the 2019 paper, they had not mentioned arthralgia, they mentioned IgA deposition. So that was a little more direct hint. Here you had to pick it up from the image and clinical features. So the answer is HSP. Then what is the diagnosis? Another image-based question. This I would say is a new question, has been asked after 5-6 years, if we call it that way. What do you see? You see multiple pigmented lesions over the face, symmetrical brown pigmentation covering the malar areas, the nose, the upper lip. What is the diagnosis? The diagnosis here is melasma. HIV with dermatology has been a recent favorite of the NEET PG as well as the INI-CT paper. So this was expected to be asked. Here, what they would normally ask you is an image of Kaposi sarcoma, but they took it a little step forward and they asked you at what CD4 levels would you see Kaposi sarcoma. Now, this is an AIDS defining condition. So if it is an AIDS defining condition, it will be seen at lower CD4 levels. The answer here is less than 200. So this was a little more than what they would ask, but I'm sure all of you could still at least guess. One thing is for sure, HIV with dermatology, tuberculosis, and dermatology. These are two upcoming topics where they are asking a question in almost every exam. So this is, Kaposi sarcoma, histoplasmosis, cryptococcosis, then certain other opportunistic fungal infections. They are a recent favorite. With this, we finish the 9 questions that were asked in dermatology. If you have any other questions, any discrepancies in the options that were given, you can always post them. We'll be coming up with a detailed review. So I hope all of you got these questions correct. Now, I would say after watching this one, do not watch any more recall videos. You are done with your recall discussion as well. Chill out, just wait for your result. I'm sure you all will be passing with flying colors.
Thank you so much, ma'am, for such high quality sessions of dermatology and very well appreciated curated content of dermatology in the DocTutorials app also. And I think you solved a very big confusion the students were having regarding herpes and chancroid. And thank you so much for that, ma'am. And moving on forward, we have a very important subject, foundation for your entire medical curriculum to understand the physiology. We have with us Dr. Naveen Powal, sir. And this subject is a core, I would say, to go ahead and understand patho and medicine. Over to you, Naveen, sir, and the insights about this exam.
Yeah, good evening, sir. Good evening, everyone. So I'm very happy because a lot of questions are from physiology, we can say directly also, and also integrated with medicine and pharma also. So I will not take much of time. So first question was, there was a formula given U into V by P. And they asked, what is this? So actually U is substance in urine, and this is substance in the plasma, and V is the blood flow. So this is about the clearance. So they were asking about the clearance. Second question were their FMG favorite. They were asking about inhibin. For last 3 years, if you see the paper, this question is coming every year. That what is the function of inhibin? So it inhibit mainly the hormone FSH. So there was a whole chart given, and they asked what is this X, and answer was inhibin. Then the third was a clinical question. A whole clinical scenario was given, and they have said that there was a lung infection, and he was having hypoxia. So they were asking about the peripheral chemoreceptor, which channel is activated. Option was sodium, potassium, chloride, like that. So we know it is oxygen sensitive potassium channel. So answer was potassium channel. Then a question was there, which part of the renal tubule absorb maximum water? Some students were saying in the presence of ADH, some were saying there was in the absence of ADH, but mind it, in the both case answer will be BCT, because 67% of water absorption either in the presence of ADH or in the absence of ADH will be from proximal tubule. So in both condition answer will be proximal tubule. Fifth was our clinical case was given in which a patient was hypovolemic shock was described, and they said that there's a decrease in the cardiac output. So what will be the main cause of that? So we know that decrease in the cardiac output will be because of the decrease in the preload, but the option given was end diastolic volume. So we know the end diastolic volume is actually the preload. So answer will be EDV. The next question was, in which condition GFR will be increased? So again, I'm telling you this topic is coming in AIMS, in NEET PG, in FMG, almost every year. 1, even 2 questions are coming from GFR regulation. Option will be like that, constriction of efferent arteriole, dilation of efferent arteriole. But on the answer that correct was there, increase renal perfusion. Because when there is increase in the renal perfusion, then that will cause increase in the GFR. Because when there is constriction of the efferent arteriole, it will decrease GFR, and then it can also increase GFR. So the correct answer will be yes. Dr. Vijayanand, what is the option? Then on the 7th question, smooth muscle. Now there were 2 questions from smooth muscles. One question was that smooth muscle calcium binds with. Answer will be calmodulin. But some students were saying that it was about the contraction of the skeletal muscle. So in that case, the answer will be troponin. So depending on the option which I get here is that smooth muscles, if they're asking it is calmodulin, and skeletal muscle will be troponin. Then the 8th question will be what are the muscle which is the protein which is absent? Yes, Bhuwana, answer is decrease in the resistance of efferent arteriole. See, when you decrease the resistance, of course, there is dilatation of the efferent arteriole. So when efferent arteriole is dilated, GFR become less. So if the question was GFR become more, then answer will be renal perfusion. And because this is coming for last 5 years in AIMS also, so this topic is often repeated. I have discussed in detail in a lot of topic we can see here. Yes. Now, exercise. Now, question was, there was a profuse, sweating. So what is the theme there regarding that? Answer was temperature regulation. So for the temperature regulation during exercise, we sweat and we vasodilate. So this is the mechanism of temperature regulation. Then the 10th question was, they simply asked the GFR. It was 125 ml per minute. Then the 11th question was integrated with medicine. ABG was given, image was given, pH was 7.18, PCO2 was 22, bicarbonate was 18.4. So we can see here that pH was less and bicarbonate is also less. So it is metabolic acidosis because PCO2 is less, so it will cause respiratory alkalosis. So answer in that question was metabolic acidosis. Yes, Bhuwana, another option was increased filtration coefficient. Yes, it is the same question that was asked in INCT. Almost options were the same. Okay. Then they asked in the trachea, what is the cilia? It is pseudo-stratified ciliated columnar epithelium. In the class, we discussed this so many times. Yes, Vijay? This was like local Vijay brought something from shop and the shop and was for adulteration. Okay. Looking about the forensic. Now, next question was, in cystic fibrosis, there is a mutation of CFTR gene. So question was that which channel is affected? So answer was chloride channel, and that is why the drug choice is ivacaftor. We know it is a chloride channel opener. Then the 14th question was regarding the ECG. Changes were in the anterior wall lead. So answer was anterior wall myocardial infarction. 15th questions were regarding secondary messenger, and the option that was correct, that it will go inside the nucleus and cause change at that level. Then the 16th questions was regarding the myasthenia gravis, in which it was given the ptosis, drooping of eyes, and condition get worsen as the day progresses. So as the day progresses, we know it is myasthenia gravis. Options were also in the Lambert-Eaton, but in the Lambert-Eaton, as day progresses, weakness become less. Okay. Then one question was regarding small breathing. Then 18th question was primary lymphoid organ was thymus. And then they asked that which hormone increase in stress as well as starvation. Now, some students were telling cortisol was also given, but cortisol will increase only in stress, not in starvation. But then in the question it was given, which hormone is going to increase in the stress also, as well as starvation and fasting. In that condition, option will be growth hormone. Then 28th question was regarding, image was given, zona, granulosa, fasciculata, and reticulus was given, but I don't know what was marked. So it can be aldosterone, cortisol, or it can be testosterone, depending on the options. So there were 20 questions which were directly from physiology. So thanks.
Thank you so much, sir. I think 20 questions in physiology. This was a very high-yield subject for this exam also.
Yes.
And thank you for your detailed discussion on that, sir.
Thanks.
We have next going forward. We have Dr. Nadeem sir for psychiatry, and psychiatry also was a short subject but a scoring subject for FMG students this time also. And Dr. Nadeem sir, your insights about the exam and the psychiatry in specific.
Yeah, sir. Thank you so much. Hi, everyone. I hope all of you have done great in your recent FMG exam, because I would say most of the questions were actually easy. And I would say a moderate paper it was. Paper 1 was very easy, paper 2 mostly clinically oriented, right? But like in psychiatry, like I asked 7 questions this time. My screen is visible now.
Yes, yes, you're audible and visible. Please go ahead, sir.
Yeah, okay, fine. Okay, so in total 7 questions they have asked. See here, so mostly frequently asked questions only. It's a very easy question. Okay, see the first question here, what they have asked. See, first question is related to a mother is complaining about her young daughter that she has started behaving weird about her food habit for last few months. She eats a lot and then she vomits out as she is scared of gaining weight. She's also indulged into over gymming. What is the most probable diagnosis? See here, anorexia nervosa and bulimia nervosa has always been an important topic. I have taught you in the anorexia nervosa, there will be maximum restriction, but more binging and more purging and image consciousness. Answer will be what? This will be bulimia nervosa. This will be what? Bulimia nervosa. Okay. Next question. See, this was related to alcoholism. See, like in psychiatry, substance abuse, minimum 1 or 2 questions they are usually asked. So related to alcohol, this question was there that this person was taking alcohol for last 20 years. See, every time 500 ml. right? Now he presented with sensation of insects, right, around his body, agitation, irritation. He took last drink 3 days before. See, I have taught you in detail, right? All the withdrawal symptoms, after 6 hours, after 12 hours, right? After 24 and after 48 hours. After 48 to 72 hours, there will be what? Very serious condition. After that, patient will be completely disoriented to time, place, and person, agitated, irritated. Patient will be having mostly visual hallucination, auditory hallucination. Here it has mentioned about the tactile hallucination. Yes, this can be seen only in alcohol withdrawal syndrome, right? So here answer will be, most of the students have said, okay, sir, like this was the option. And some students said, okay, sir, it was mentioned delirium. So whatever, answer will be B here. Okay, alcohol withdrawal after 48 to 72 hours. All right. Next question. See the third question. A person is afraid of seeing the tall buildings and looking down from the very height. Basically, fear of height. Simple question, one-liner question. Fear of height is what? Acrophobia. Acrophobia. Here, like most of the students, you would have easily ruled out, right? Claustro means only closed part, right? Agora means what? Like multiple, like more than two. Closed and open both, right? Okay, see next question. Okay, see this question here now. A known case of depression in the past who got recovered completely. After 5 years, patient started to feel low, hopeless about future, negative emotion, lack of interest, depressive episodes, right? Basically, 5 years before, see, this patient had a depression. Now patient is having depression again. So this is nothing but recurrent depression. Okay, recurrent depressive disorder. Next question, very easy question. See here, like most of the students told me that this question was very, very big. Okay, fine. So basically very big question, and like they have written so many sentences, but overall what I could recall, this was about what? This was about the Wernicke's encephalopathy. That, see, history of alcohol, and after that there was what? Eye problem, walking problem, and he was mentally confused. Basically, we have learned about Goa, right? So global confusion, ophthalmoplegia, ataxia. Okay, and after that, examiner has mentioned what? History of alcohol was also there, right? So see here, so this is an emergency condition. This is an acute condition. This is called as Wernicke's encephalopathy, right? Wernicke's. So this is because of what? So here, how to treat? Most importantly, vitamin B1 injection as soon as possible. We have to give the injection, right? IV injection of what? Thiamine. How much dose? 250 milligram, which I have taught you. Next question. Which of the following is not a defense mechanism? Yes, this was one-liner question. And this I have taught you in psychoanalysis about ego, super ego, right? All unconscious domain about ego. So which is not a defense mechanism? I have taught you, right? Sublimation, displacement, altruism, right? When you help other people, you feel good. Altruism, right? Shifting of emotion. So here we can rule out replacement. Last question, very easy to understand. So almost similar question they have asked in FMGE last time also, right? See this question, a patient was taking metronidazole for diarrhea. After that, he went to attend the party of his friend where he had alcohol. After that, he started having red rashes, itching all around his body, and headache. Okay, fine. Basically, this is, see, these are the symptoms which are related to disulfiram ethanol reaction, right? Which can be seen in some, like some drug users also, like metronidazole, ketoconazole, isoniazid. So many drugs are there, which you would have learned in your pharmacology also. So here you can mark what? B. I'm sure you would have done great in psychiatry, 7 out of 7. I hope so. Thank you so much. I wish you all the best.
Thank you so much, sir. I think students must have had a good strike rate in psychiatry. And going forward, we have another important subject, the preclinical subject, biochemistry, and it has been tested heavily also this exam. And to take you through biochemistry, we have with us Dr. Nilesh Chandra, sir. Sir, your detailed insights about biochemistry in this FMG exam. Students were with a lot of, happiness after the first paper. And I think even biochemistry was doable. Please, your insights, sir.
Thank you, sir, for inviting me here. And hello and welcome, everyone. I'm sure, like sir said, everyone's very happy with the biochemistry section. I think except one bouncer, everything was along the expected lines. Like we keep telling you, the acid-base disorders you'll always get vitamins. You'll always get 4 or 5 questions. The inborn error of metabolism you're always going to get. Toxins, markers, enzyme inhibition. These are the ones which you're always going to get. A lot of questions are applied clinical, so you will find most of them have already been mentioned somewhere, either in medicine or in psychiatry, or so in different places we have had mention of some of these questions. So I'll quickly recap the questions from the biochemistry section for you. The first one was acid-base disorder. Already just now, Daveen sir has just discussed, so I'll not go into that, where he said we had the metabolic acidosis as the question. So that was question number one. Then bite spot, again discussed by ma'am in ophthalmology. Shivani ma'am has talked to you about white spot, vitamin A deficiency. Another question, niacin deficiency, again shown by ma'am in Dharma. Pallavi ma'am had shown you Casal collar, also mentioned by Rajiv sir. So niacin deficiency presenting as the Casal collar, also known as Casal necklace. Basically, like sir mentioned, in the photosensitive regions, you have this presentation. Then Wernicke's just now, Nadeem sir just discussed the Wernicke's encephalopathy, where you were supposed to identify what should be the treatment. Wernicke's is the classical presentation in patients who are consuming alcohol on a chronic basis, and then sir mentioned they present with the symptoms, classical symptoms of Goa. So there, the treatment related question was there. This was the only bouncer, I would say, because this is a term which we generally don't mention when we are discussing the vitamin D deficiency. And already Rajit Dhawan sir has mentioned this when he was talking about the larynx, the laryngismus stridulus, laryngeal spasm in vitamin D deficiency. Except for this question, I'm sure the students would have been very, very confident about all the different questions which came from biochemistry. The oil drop cataract, classical galactosemia, again mentioned by Shivani ma'am, that oil drop cataract question was there. So you see, whatever biochemistry was there, it's mostly applied biochemistry was there. Then we had the question on Lesch-Nyhan syndrome. This is one of the very commonly repeated questions. I have shown you different images. I'm not sure which image was there in the question, where you have to tell about the enzyme deficiency. So this enzyme deficiency is the most commonly asked aspect of the Lesch-Nyhan syndrome. You should know this. And one of the classical presentations is the self-mutilation. So either in the question, in the statement form, or in the image form, they'll always mention the self-mutilating tendency. In children, the only differential diagnosis for self-mutilation would be the Lesch-Nyhan syndrome. If it were adult, then you can have a different differential. But as soon as the question says self-mutilation, children, immediately your answer should be Lesch-Nyhan syndrome, X-linked SGPRTS deficiency. Zellweger syndrome, again, two faculties already mentioned that there is the peroxisome functional defect. Either the peroxisome is absent or the peroxisome is empty, means the structure is there, but the enzymes inside the peroxisome are not there. You know, peroxisome is required for the metabolism of very long chain fatty acids or the branched fatty acids. Okay. So Zellweger syndrome is associated with the defect in peroxisomal function, also known as the cerebrohepatorenal syndrome. Chai red spot, again mentioned twice already. The important thing to remember is when they say chai red spot with no organomegaly, that is when should become alert. This is the case when we are talking about Tay-Sachs disease. Remember, in all the sphingolipidosis, you have organomegaly. Exception is the Tay-Sachs disease. Chai red spot is one of the common findings, one of the very common findings in the sphingolipidosis. So there, if they mention no organomegaly, then you should start thinking about the Tay-Sachs disease. Then again, Hartman's disease already mentioned previously also, where there is defective absorption of multiple amino acids. 13 amino acids are not getting absorbed in Hartman's, but the clinical presentation is that of tryptophan deficiency. So it will present as pellagra. So, all right. So tryptophan deficiency. What is tryptophan deficiency? Here the niacin is formed from tryptophan, so the presentation will be that of pellagra. So I was not very sure about the options which were there in the question. So I'm telling you these three things: that the gene defect, which is for the transporter from the urine, the absorption of amino acid has to happen. So there the transporter is defective. It manifests as tryptophan deficiency, and effective absorption of multiple amino acids, large neutral branched amino acids, they are not getting absorbed. This unconjugated hyperbilirubinemia, again, Rahul Rajiv sir already mentioned that in the given options, you had the Gilberts. Okay, so Crigler-Najjar type 1 and 2 and Gilberts, these are the inherited unconjugated hyperbilirubinemia. The inherited conjugated hyperbilirubinemia will be the Roters and the Dubin-Johnson. Pedigree chart also mentioned. I've just reproduced it for your reference. The question was about mitochondrial inheritance. Okay. So here what you have to remember, that a female transmits disease to all offsprings. Okay. And male does not transmit the disease at all. So, okay. So this inheritance pattern is unique for mitochondrial DNA disorder and not seen anywhere else. Again, the mechanism of diphtheria toxin already mentioned previously. You know that it causes the ADP ribosylation of elongation factor 2, and the amino acid is the diphtamide. The diphtamide is the amino acid which is targeted for the ADP ribosylation. This is an exotoxin coming from Corynebacterium diphtheriae when it is in the lysogenic phase. Okay, so these are the points about the diphtheria toxin. Then neuroletharism question was asked, just now mentioned that it is due to the beta oxalyl aminoalanine. Please note that the homoarginine can also cause neuroletharism. So if you get a question neuroletharism, first option is not there, then don't forget the name of homoarginine. Another molecule coming from the same species of plant, okay, that is the BAPN, another amino acid which is coming from the same species, and this is responsible for osteoletharism. Okay, this is responsible for osteoletharism. Last year we had this question that in one village all individuals are consuming the same food and having the similar skeletal deformity. So in these patients, which vitamin you will give? So please note they are repeatedly asking the question from this plant, which toxicity is there. So this time it was neuroletharism. Last time it was osteoletharism, but there they had asked which vitamin supplementation will help. Okay, so it's the same topic getting repeated again and again. Markers of MI discussed in detail by Rahul Rajiv sir, so I'm not going there. Like sir said, if this is there in the option, this would be the earliest marker. If it is not there, then you go for myoglobin. If specific component is asked, it is troponin. If they mention enzyme in the question, please remember this point. If they mention enzyme in that question, only answer which can be there is CKMB. If they don't mention enzyme, then depending on what is mentioned, any of these would be possible, depending what is in the options and what they ask. But as soon as they mention enzyme, the answer becomes CKMB. So I'm not sure whether the enzyme part was mentioned or not. If it says enzyme, answer is CKMB. If it says earliest, Asia modified. If it says most specific and enzyme part is not there, then it would be troponin. Fashioned syndrome, again, already mentioned. Marker is HIA in urine coming from the serotonin metabolism. Excessive serotonin is formed, so it will get metabolized into the 5-HIA. Hydroxyindole acetic acid coming in the urine. Marker for the carcinoid syndrome. This question also previously mentioned, inhibition by methotrexate. Which enzyme? Which enzyme is targeted by methotrexate? Answer is dihydrofolate reductase. When you are converting the UMP to the TMP, when you're converting UMP to TMP, here the tetrahydrofolate is used. This tetrahydrofolate is recycled, where the enzyme dihydrofolate reductase is required. So you can target the dihydrofolate reductase. Another target here by a different enzyme is the thymidylate synthase. Here you will have the 5-fluorouracil. So next year it will be 5-fluorouracil. This time they asked about the methotrexate. Okay, lactulose composition, repeat question. Just last year, this question was asked. Now you have to read the question carefully. There are two questions which are possible here. I could not get the clarity from the students. If they are asking about the composition of lactulose, lactulose is a disaccharide. It is made up of galactose and fructose. If it says lactulose syrup contains, then the answer changes. Lactulose syrup, in addition to lactulose, it contains small amount of galactose and lactose. Okay, so the question, if it says composition, the answer is galactose and fructose. If it says lactulose syrup contains, in that case, the answer is galactose and lactose, which are there in the mixture. About 1 to 8% of each of these components will be there. So it depends on what they asked in the question. What was the statement? I'm sure everyone knows about this. This is such a common investigation that there is a no-brainer. Long-term glucose monitoring up to 3 months old picture given by the value of HbA1c. You should also know what is the diagnostic cutoff for HbA1c, what is the pre-diabetic range. So these values you should be knowing for HbA1c. CRISPR-Cas9 was mentioned. It was asked for what purpose it is used. I'm sure all of you know it is used for gene editing. It has been in so much in the news, and the Nobel Prize has been given. And now we have a lot of techniques which are based on CRISPR-Cas. Just last year, the treatment for HPS approved by CRISPR-Cas in the US in November. And currently in the country, a lot of disease under investigation for treatment by CRISPR-Cas. Okay, so repeatedly they'll be asking you CRISPR-Cas used for what? Because now it is a reality. We have treatment modalities available which utilize the technique of CRISPR-Cas. Sir just discussed, Naveen sir just discussed the formula for urinary clearance, which was given in the question. So please remember this, the urinary clearance. There are a lot of points about urinary clearance which keep getting asked one way or the other. So this is one of the very common repeat topics that we always cover when we are talking about the general biochemistry. So as you can see, almost all the biochemistry was applied, and except for one bouncer, I'm sure all of you would be very, very happy with the biochemistry section. I always say the biochemistry section is one place where you can score 100% marks if you devoted a little bit of time to the highlighted topics which you always mention, must-do topics. There was no I would say rare topics asked this time as usual, and I'm sure all of you have done very well. As you have said, the part 1 was simpler compared to part 2, and I think the biochemistry would have contributed most to the feeling of safety that you have from this section. Thank you very much. Thank you, sir, for inviting me for
Thank you
this
so
session.
much, sir. A very well organized and very productive session, and you made it very crisp and very lucid. After this discussion of biochemistry, we have a very important subject of pathology, and to take you through, we have one of the best pathology faculty in the country, Dr. Vandana Puri ma'am. Warm welcome, ma'am, and it's a pleasure to have you here, and students must be eager to go through pathology with you. What's your opinion about the insights of the questions, ma'am, in pathology this year?
Thank you so much for inviting and giving a good introduction of me. Thank you so much, sir. I think pathology, so most of the questions were from previous year topics only, except 1 or 2 bouncers. Majority of the questions were from previous year topics, and I'm sure the students would have been able to answer majority of the questions. So that was what I feel. Okay, sir. So shall I start? Everything is visible.
Yes, ma'am. Yes, ma'am. You're audible. The screen is shared.
Perfect, sir. So let's quickly go through it. So first question was splenectomy is contraindicated, and so remember there was a lot of controversy in students also asking me this. There's no controversy in this. It's a very clear-cut answer: bone marrow failure. Why? Because if there is bone marrow is failed, obviously, who's going to do erythropoiesis? Spleen only, no. So you can't remove spleen. If you remove spleen in bone marrow failure, it's gone. So then we never ever do splenectomy in bone marrow failure. What about ITP? So in ITP, who is eating the platelets? Spleen is eating the platelets. So definitely the last resort of treatment is your splenectomy. Although it is last resort of treatment, as I say, but we do splenectomy as a last resort in ITP. Rupture, we do it. Hairy cell leukemia, we can do it. Right? So bone marrow failure, we never do splenectomy. The second question that was there was again a very simple question. So this was a 40-year-old patient. Hemoglobin was low, reticulocyte count was low, WBC and platelets were normal, and there were decreased erythroid precursor. Name itself says only erythroids are decreased, all the other things are normal. So it's pure red cell aplasia. Why this is not aplastic anemia? Because WBC and platelets are normal. Remember, in aplastic anemia, neutrophils usually fall earlier, apart from low reticulocyte count and thrombocytopenia. Okay. Coming to the third, this is mitochondrial pedigree. All of you know that. Okay, so when the mother is affected, all the children gets affected. Whereas when the father is affected, nobody is affected. So it was mitochondrial. This was a simple karyotype. You all know this is trisomy 18, which is Edwards syndrome. Coming to the next question, which was also a very tricky question. Please remember, this is a very beautiful image from Robbins, and we have also discussed it in this app also. So remember, whenever they give you a history of cleft lip and cleft palate with mental retardation, this is very typical of Patau syndrome. Whereas whenever they have to, these are three very classical images which are given in your Robbins textbook. So cleft lip and cleft palate should take you to Patau syndrome. Okay, whereas simian creases and all should take you to Down syndrome. Okay, so this was another question which many students asked me. Which of the following is a primary lymphoid organ? Remember, there are two primary lymphoid organs always, bone marrow and thymus. That's it. There's no controversy in this. So primary lymphoid organ is thymus. Spleen, lymph node, malt, all these are secondary lymphoid organs. Okay. Coming to the next question. So which necrosis is seen in pancreas or raised serum amyloids? Remember, always fat necrosis is commonly seen in pancreas. Okay, so this we have also discussed in detail in app also. Okay, so diarrhea with dermatitis herpetiformis. Remember, whenever we talk about diarrhea with the dermatitis herpetiformis, these are all IgA mediated diseases, and these are very commonly associated with celiac disease. So what is the main cause of anemia in geriatric age group? So please remember, iron deficiency anemia is a very common anemia in any age group in India. Whereas when we talk about developed countries, then if you think of anemia of chronic disease, then yes. But otherwise in India, nutritional anemias are very, very common. So go for iron deficiency. In fact, in anemia, whenever iron deficiency develops in the elderly, we should always think of an occult blood loss, which can be due to malignancy. Okay, so this is a diagram which is from anemia of chronic disease. So in anemia of chronic disease also we can have a status of there are various pathways which work, so it's an hyperinflammatory state. So this anemia of chronic disease, although it is common in geriatric age group, but it is less than iron deficiency in our country. Okay, so this is just a chart for all the causes of anemia in geriatric age group. So again, there was a question, microcytic hypochromic cells can be seen in all except. So remember, always, all of you know the code CETA. Okay, so that is sideroblastic iron deficiency, thalassemia, and anemia of chronic disease. They are cause of microcytic hypochromic. Anemia due to blood loss is usually not microcytic hypochromic. There is a lot of reticulocytosis in it. So therefore, it can be normocytic normochromic also. Okay, so this was a tentative question that I had put in my Instagram also one day before the exam. So this is one of the favorite questions of the examiner always, and these are outliers which I discussed. This is typical CMV. You will see a lot of cytoplasmic inclusion and a perinuclear halo. This is CMV. I hope everybody marked it correct. Please remember, blueberry muffin syndrome can be seen in any torch infection, especially remember CMV can also cause blueberry muffin syndrome. So do not get confused with it. Okay. So this was layers of adrenals which was asked, and we have also discussed this in app also. There is glomerulosa, fasciculata, and reticularis, and all of you know that the reticularis was marked here, and they asked what does it produce? It produces androgens. Okay. So this was again a tentative question which I had added on my Instagram just before the exam. Multiple rings, a pole, and banana-shaped gametocyte is a very typical of falciparum. This is the image of the Instagram post only that I had posted. So just to tell you that whenever there are multiple rings, you should always think of falciparum. And this was also a tentative question that I had posted on Instagram on the treatment of pneumocystis came, but I hope you will be able to identify pneumocystis with the crushed ping pong ball appearance, which I had again posted on Insta. So Mallory bodies, this we have discussed so many times in the app also, in the quick revision sessions also. These are made up of intermediate filaments, especially CK8 and CK18. So now this is very important. So this question has a little recall bias, I think.
So this was given us in a term of OH negative or OH. OH, guys, is always for Bombay blood group. Okay. So whenever H antigen is absent, we write it as small h. So small h is always Bombay blood group. So if this was the option that was given in the Bombay blood group, we can only give Bombay blood. Okay. So Bombay blood group should receive blood only from Bombay blood group. We cannot give them O positive or O negative because all of them have H antigen on them. And if we give this blood to Bombay blood group patient, they are going to get acute hemolytic transfusion reaction. So you have to tell me whether it was H negative or just O negative. So if it is just O negative, that means it is, they are talking about O negative means that is capital D, that is D antigen is negative. Okay. So in such cases, if it is O negative that was given in your exam, then you can give blood from O negative patients only. However, if it was OH, that means it was Bombay blood group, then you have to give blood from Bombay blood group only. Okay. So just think what was there in exam. Okay, so there were, I've just posted 3 images. So students gave me different recalls. So if this was the image, you can see the little bulging appearance, but a very smooth cut appearance, like a potato cut potato appearance, then this is seminoma, guys. If this was the appearance, if this was the appearance with a lot of mucoid areas, okay, so then this is yolk sac tumor, and this everybody knows this is teratoma. I've just added it like that. Okay, please remember this was also a question. So which testicular tumor has the best prognosis? So remember, prepubertal yolk sac tumor always have a very good, excellent prognosis. Okay, so prepubertal yolk sac tumor has an excellent prognosis, usually occurs in children less than 2 years of age, followed by seminoma. So CRISPR-Cas9, already you know, this is a gene editing technology, and again we have discussed about it in app also. So this was also a very important question. Okay, CD4 count in HIV associated with Kaposi. So Kaposi sarcoma usually occurs whenever the CD4 count is usually less than 500. Okay, so Kaposi sarcoma usually occurs at an earlier age. Okay, whereas you know, whenever the CD4 count starts falling down, less than 200 is pneumocystis, less than 50 or less than 100 CMV can start, and less than 50 is for CMV. So this is one of the very important tentative questions, especially in HIV. They usually ask CD4 count and what are the malignancies that can occur in HIV. This is one of the favorite questions of examiners. You should know that. Tumor marker of carcinoid, it has been discussed just now in biochemistry. It is 5-HIAA. Okay, so this was a INICT level question. So this was a tricky question which has not been discussed anywhere till now, and it was a tough question. Hexanucleotide repeat disorder. So it was not trinucleotide repeat. Normally you have studied trinucleotide repeat. Is it that the code that you remember? Hunter keeps everybody in the cage, or if there is a fragile X, it will say CGG. Okay, or if it is Friedreich ataxia, it will say JA. So these are trinucleotide. We are talking here about hexanucleotide repeat. That is 6 nucleotides together are repeating. So this is a very upcoming topic, and a lot of disorders have been found to have hexanucleotide repeat. But commonly these two have been mentioned. That is frontotemporal lobar degeneration and amyotrophic lateral sclerosis. I think frontotemporal lobar degeneration was in your option. So remember, this is a hexanucleotide repeat disorder, and this is one of the INICT level question that I should say has come. So this was again a simple question: Lisch nodules, capillate spots, and diagnosis. This is NF1. All of you know that. So there was an image of Langhans giant cell. You know, this is a horseshoe-shaped nuclear arrangement. This is very typical of Langhans giant cell, which is seen in tuberculosis. Also, there was another question: what is the type of calcification that you see in granuloma? Whenever we have a granuloma, it's a dystrophic calcification. And whenever there is a dystrophic calcification, you already know the calcium levels remain normal. Whenever we have an increased calcium level, it is metastatic. So remember, granulomas usually cause dystrophic calcification. So TB is an important cause of dystrophic calcification. So usually, this granulomas, if there was an image given with it, that is TB granulomas, can be associated with dystrophic calcification with the normal calcium levels. Again, this is a very important repeat question. What is a negative acute phase reactant? All of you know albumin is a negative acute phase reactant, and it's a repeat question. So these are my channels which you can follow. Apart from the app on DocTutorials, these are the Instagram channel, Telegram, and WhatsApp channel, which you can follow. And I am sure you would have done pathology very nicely, because majority of the questions were previous year topics, and all of you were very good in quizzes also. So I expect a very good result from all of you this time, and I'll be happy to hear your success stories. Thank you so much.
Thank you so much, ma'am. I think a high quality content, especially the Bombay Blade Group discussion, also a lot of clarity the students must have got after this discussion, and really appreciate the quality content that you keep posting and supporting the students with, both on your social media and also on the doctoral lab, ma'am. And towards the end, I think it's been a long session, and Sandeep sir has been patiently waiting. And a warm good evening, sir, and I think early morning for you now, but thank you for the patience, and students love you for your pediatric sessions throughout the country, and they would be happy to, listen from you about the recall of pediatrics in FMGE July 2024. Please go ahead, sir. I think you need to unmute, sir.
Good evening, sir. Thank you so much for
yes, sir.
Can you
yes, sir. We can see your screen, sir.
Am I okay, sir?
Yes, sir. You're audible also.
I'm audible. Am I visible also, sir?
You're audible and visible. You can share the screen, sir.
Okay, sir. I'm sharing the screen. Okay, thank you so much, sir. No problem at all. Such wonderful faculty members have shared their inputs, and I'm quite sure students who are watching live and those who will be watching this video later on, they are also going to benefit from it. So it's not just a recall session. We are also trying to discuss how the paper went, and you can calculate where you stand right now. At the same time, for those people who will be sitting in the exam later on, you'll have a fair idea how the things stand right now. And so the FMGE July 24, I know it's midnight, so I will not take much of a time. I'll try to focus on only the bare minimum important things that you people need to know. So first of all, the overall exam pattern, I'll be summarizing. Overall level, it was easy to moderate. If you don't know the exam, you find it tough. If you know the paper, you find it easy. But in general, based upon a lot of students that we asked, the overall level, combining paper 1 and 2, it was easy to moderate level. The paper 1 was easy. There were a lot of one-liners, and although it does happen sometimes, but about 7 questions of pediatrics were there in paper 1, and some applied questions were there in paper 2. So paper 1 was easy. Paper 2 was moderate level with occasional tough questions. Slightly tougher questions were asked in the clinical case scenario. Surgery was on the tougher side. A few questions from Ops Gynae were looking to be easy, but they were slightly on the tougher side. There were some numerical questions in pediatrics, which I would, agree that they were on the tougher side. But apart from that, overall exam paper was on the easier side. So the unique observations from my end, there were more image-based questions in this exam compared to last year, especially in paper 2. Many chest x-rays were asked, many radiology images were asked, many procedure images were asked. And so your integrated subjects like radiology become very, very important. More integration was there in paper 2. More applied portion was there in paper 2. Paper 1 was one-liner based. Paper 2 was integrated clinical oriented paper. And expected topics continue to be asked. This is something very important. It is not that the paper was out of this world. Even in lengthy questions, there were expected topics. So if you are thorough with the previous year topics, you would definitely have an edge in this paper. Medicine and surgery are becoming more and more conceptual, less and less one-liner based. So people who are targeting the major subjects, you need to be very clear in this, that the days of one-liners in medicine and surgery is gone. You need to now prepare in a more clinical oriented manner. And this is a pattern we have seen in NEET PG also, in INI CET also. So all the exams are more clinical. The clinical papers, the clinical subjects are more conceptual. So you need to prepare accordingly. And there were less PSM and OBG. Yes, there were questions, but there were less PSM and OBG compared to previous years. OBG, there were a lot of questions which were overlapping with pharmacology, pathology, as well as PSMs. A few were there overlapping with medicine as well. So compared to last year, the weightage was less. And PSM being less is something I know many FMG students will be very happy about. So coming to my subject, that is pediatrics. Pediatrics traditionally has always been a scoring subject, and it was solvable and high scoring. By solvable, I do not mean easy. By solvable, I do not mean ki all one-liner based, but about 95% questions, I would say they were solvable if you have prepared well. And so if you can score 90 or 95% in any subject in FMG, you know that it is a highly scoring subject for you. 1 to 2 questions were tough. I will come to the questions which were on the tougher side. There were 2 numericals in pediatrics, one on stature calculation and one on fluid calculation. Milestones continue to be asked. Last paper, there were 2 milestones. This paper, there was 1 milestone, and the milestone was on the easier side. It was a gross motor milestone, something that we have already discussed, the table that we have discussed in DocTutorials app, in my classes on Arise Academy. You would have seen that table of gross motor milestone. If you just remember those 4 or 5 points which are mentioned, it would have been easier for you. But again, you need to remember it and apply it in the paper. Syndromes were asked. Severe acute malnutrition was asked. Previous paper did not have kwashiorkor marasmus. I had told you, if Kohli gets out on 0 in one exam, in one match, he will perform when it is needed. And just like Kohli did in World Cup final, you had marasmus coming here as well. Direct pure pediatric questions were about 12, and integrated overlap questions, if you take them, about 18 to 19 questions from pediatrics were there. So if you're thorough with it, out of those 18 to 19, you can easily score 16 questions correct out of those 18. It's a huge number, and that is why a child is always very important in FMG exam. So what were the topics asked? The detailed recall we'll be doing later. There was a question milestone on child is able to ride a tricycle. He's able to walk upstairs and downstairs alternate feet, but unable to hop. So hopping comes at 4 years. So it should be less than 4 years. Some students said, sir, one of the option was 3.5 years, and that would be the logical answer. So between 3 to 4 years, the age of the child was likely to be. Similar case scenario we have already discussed in the class papers, in the class MCQs, which whatever offline class that I take with you. Second, there was a marasmus question, which was on the easier side. There was a question on the hemophilia inheritance. There was a triple bubble appearance, exact image, what is given in standard textbooks, what I have discussed in the class also that was asked. Triple bubble and jejunal atresia was the answer. It is a overlap question. Surgery, radiology, pediatrics, whatever place you have read, it all comes down to whether you recall it in the exam or not. Hartnupp's disease IEM question was there. Bite at spot was there. Compared to previous year, the questions on micronutrient deficiency were slightly lesser. Metabolic disorders were slightly lesser, but at the same time, the traditional questions were there. So bite at spot, vitamin A deficiency was there. There was a question on NF1. There was a question on neural tube defect. It was a radiology question where they were asking about the lemon and banana sign. So that question was there. Then nutritional index question was there. Wasting they had asked, and weight for height was the parameter. Nutritional index and SAM would surely be asked. If you remember, I had discussed in my classes and revision classes as well. So there was a tough question, daily fluid requirement in a 3-day-old baby with birth weight 1300 gram. Some people said there was an option of 120, some said 130, some said 110. It will all come down to how the option has been framed. But generally, if the birth weight is less than 1500 grams, day 1, we start 80 ml per kg per day. Day 2, we make it 100 ml per kg per day. Day 3, we make it 120 ml per kg per day. So 20 ml per kg we increase in a preterm or low birth weight child. This is the general rule that we follow. So it was slightly on the tougher side, but not entirely unexpected. Then CFTR gene channel is a chloride channel. It's an easy one-liner on cystic fibrosis. There was a karyotype image they had asked, and they had asked you to identify and make the diagnosis. Some people said, sir, there was trisomy of 18. Some said trisomy of 13 was there. So likely it was either Edward or Patau syndrome based upon what karyotype was given to you. And mid-parental height numerical was asked. So remember that in a male child, when you are calculating mid-parental height, you add 6.5, you don't subtract 6.5. In a girl child, you subtract 6.5. In a male child, you add 6.5. Father's height plus mother's height divided by 2 plus 6.5. If your mathematics is right, you will get the answer correct. Then neonate with weak lower limb pulses, it was a repeat question. It's a NEET PG and INI-CET question. There was a case scenario on this, and coarctation of aorta was the answer. There was a question. Some people said some newborn was mentioned. Some said some newborn was not mentioned. But they were asking about, there are 2 variants of this question. One student has said, sir, there was neonate with unconjugated hyperbilirubinemia. Some people said, sir, it was inherited unconjugated hyperbilirubinemia. So that that is Gilbert syndrome. Sash is saying, sir, repeating the same question again. Sash, because integrated questions are there. So if an integrated question is there, it can be there in radiology, it can be there in pediatrics, it can be there in any other subject as well. So you are supposed to mark in the exam according to, so the topics, the questions I'm discussing are related to pediatrics. So you need to be a bit more mature and smart in this. Then topics, some more questions were asked. There was a mitochondrial inheritance image. There was an inheritance pattern. Pedigree chart was given, and they had asked the inheritance, and it was only mother transmitting to all her children. So mitochondrial inheritance was there. There was a tough clinical question asked on cretinism. The answer to that question was cretinism. So IV fluid of choice had been asked in a child. Very clear. If it is a SAM child, IV fluid of choice is Ringer lactate in 5% dextrose. If it is not a SAM child, your IV fluid of choice in severe dehydration will be Ringer lactate alone. This is something, again, we have discussed many times in the class. Even in my T&Ds, I have discussed this. On the QRP of DocTutorials also, I have discussed this point as a table, if you remember. Diarrhea and dermatitis herpetiformis were the keywords, and the answer was celiac disease. It was a medicine and pediatric overlap question. And then there was an ENT overlap question, laryngomalacia. This is something that Rajiv sir also teaches. I also teach. So based upon whatever, doesn't matter from where you have read, laryngomalacia inspiratory stridor was another question. If you count the number of questions, it is about 19 here. So 19 to 20 questions, including overlap questions I have discussed here. There will be repetition because all faculty members have collected their own resources and students have shared with them. All this is based upon recall. If there are some more questions or some alternate question, we will be compiling it and we'll be coming out with more detailed recall sessions for this. Right. And in the end, all I would like to say is the paper was solvable. And personally, I believe the pass percentage this year is going to go up, which is a very, very good thing. So just hoping to hear a lot of happy messages when the results come out. At the same time, some people have said, sir, I made a few silly mistakes. Life is like that only. We all make silly mistakes. I made a few silly mistakes today also. The only difference is I'm not giving an exam. You are sitting in the exam. I hope all of you do well, and wishing all the students best of luck. Whatever was done whatever had to be done is done. Now focus on your health, getting good sleep, and just keep fingers crossed. Have belief in God, in your work, and let's hope things come out well. That's all from my end. Khalil sir.
Yes, sir. Thank you so much, sir.
Comments, sir.
Yes, sir. Yes, sir. I think I'll just share the screen. I will quickly go through the radiology discussion. I missed out on that discussion part. Can you?
Yes, sir. I'm doing, sir. I'm doing.
Okay. Is the screen shared, sir?
Sir, I don't have the screen. Like I've removed my screen, sir.
Okay. Oh.
I'll just ask Karthik, sir.
Yeah. I think in radiology, we had a very good number of questions. A lot of images asked. There was questions on PET-CT identification. There was a question on identification of the radioisotope used in PET scan. There was a question on the most radiosensitive organ, that is testis. Image of miliary TB, banana sign and lemon sign, the neural tube defect. There was a question asking about a patient who was having renal calculi, elevated serum calcium, parathormone, what investigation to be done. I think system scan. And the other thing that we had was a triple bubble appearance of jejunal atresia. And there was one image of ERCP and with biliary, with a stent in the bile duct, and another option was percutaneous transhepatic biliary drainage. I think most of the students are saying that the answer was percutaneous transhepatic biliary drainage. Then we also had skull radiograph asking about cotton wool skull, the Paget's disease, and PSMA PET for prostate cancer. There was an image of hollow viscous perforation. Then we had the image of monod sign, aspergilloma, And some students said they were question asking about left renal mass on a CT scan, and liver segment 8 was asked. One image of PCOS, ultrasound image, and OBG gynecology topic was also overlapped. So radiology also was a heavy exam. And I think, Sandeep sir, can you just handle it? I think there's an issue with my screen now. Khalil sir, I think your screen is stuck.
Yes, sir, you're visible.
Is the screen shared, sir?
Yes, sir, it is visible, sir.
So we'll conclude with the radiology discussion. Radiology was heavily tested in this exam. I'll just go through the questions that were asked. One question was a patient suspected of malignancy, and the investigation was given. And you can see the bones are white, and there is tracer uptake in the brain. So this is glucose radioscope that is used. This is PET CT image. The bones are white, and there's tracer uptake in the brain. Then they asked you what is the most radiosensitive organ. This is law of Pergoni. The undifferentiated cells with high mitotic activity like the gonads are radiosensitive. And if a bone marrow was there, that was the most radiosensitive tissue. But here it was just bone, and testis was the option. So go with testis as the answer. So the answer here is testis. The next thing, the patient has low-grade fever and cough, and a classic image of miliary TB. You had millet seed-like opacity bilaterally, diffusely in both lungs. This is something we should not miss out. And another question, banana sign and lemon sign on antenatal scan. This is seen in Chiari malformation as well as spina bifida. They did mention neural tube defect, so spina bifida or neural tube defect will be your answer. Then other question showing a patient with multiple renal calculi, elevated serum calcium and parathormone levels. They asked you what is the investigation. So parathyroid adenomas are evaluated on technetium 9nm System AB scan. Then they gave a radiograph, abdominal radiograph, showing you triple bubble appearance, that is jejunal atresia. And there was one image that was given that showed percutaneous transhepatic biliary drainage, and that was the answer for this patient with obstructive jaundice. And another radiograph, skull radiograph given, which showed osteoblastic areas in the skull, that is your cotton wool skull, feature of Paget's disease. And gallium-68 PSMA PET. This is used in prostate cancer. PSMA basically stands for prostate-specific membrane antigen. So you just needed to know the full form to be able to answer that. Prostate-specific membrane antigen is for prostate cancer. And a radiograph which is always asked in your exams, patient with acute abdominal pain after an episode of binge drinking, the radiograph is given, and you are seeing air under right hemidiaphragm. This is hollow viscous perforation, hollow viscous air under right hemidiaphragm. Please think of hollow viscous perforation. And there was another image, old TB patient with hemoptysis, and the chest radiograph showed the Monod sign. Okay, you can see the crescentric area around the cavity in the lung. This is Monod sign. Monod sign is feature of fungus ball or aspergilloma. And they said, some students gave the thing that there were different questions on PET scan. One was the identification of the modality. One was asking the isotope that is used, that is 18-fluorodeoxyglucose. And that is based on the glucose uptake. One CT scan image on left renal mass, and one question was there on hepatic segments also. The segment 8 was asked, and I think that was a surgical question that was out of liver segments. Another image was an ultrasound image in PCOS. So these were some questions, right, that were asked. And one thing that I would like to tell, the paper was doable if you had studied well, and I hope that, as Sandeep sir said, the pass percentage should be high. And I just want you to, understand the kind of quality training that is happening at DocTutorials and the kind of, effort that the entire team at DocTutorial puts to see that, high quality content, rich content. And these are something that has all been taught in your classes, in your apps, right? In your, revision sessions that we do at DocTutorials. So the kind of impact and the quality training that you have, you can be assured and with the team. And I'm sure this insights into the session will help you have a better understanding of the concepts. And thank you so much to everybody for joining so late with us. And PCOS was not there. Okay, so that must be a thing. Okay, any feedbacks that you have from your side, please do mention from your side. We will be happy to look into it. You can put in the social media for all the individual faculties also. And PET scan was a hot topic. Nuclear medicine heavily tested, right? So this time, so strongly suggest everybody of you not to miss out on any chapter. Especially radiology is becoming much high yield, and also even clinical subjects. A lot of images are coming. So your surgery images and all are becoming high yield. So for all the future aspirants, give high weightage to this, and pretty much not very difficult paper, and at the same time not something which will go superficially to the examination. So thank you so much to all the faculty team. That the kind of impactful session we had this time, I think, must be useful to all the students. Hope you all enjoyed the sessions. Do let us know, and you can connect to all the faculties with your feedbacks about the questions. We'll have a complete detailed questions coming up on the app, and hope you all will have a very high pass percentage, and all the best from the entire team of DocTutorials for good results. Okay, thank you so much, and good night, everybody. Thank you, sir.
Good night, sir. Good night, everyone. Thank you.